African Americans, the prevalence is maybe a little bit higher than in the general population at about 0.9%, and it seems to go across other cultures too. When you look at Israeli adolescents, it hits about 1%. So it tends to hover roughly between, right around 1% in terms of prevalence rate. Another issue is when you have trichotillomania, you have a much greater likelihood of having other what we call body-focused repetitive behavior conditions. You're much more likely to have things like skin picking. In fact, the evidence says that about 51% of people who have trichotillomania also pick their skin on a regular basis to the point where they have significant damage. 20% bite their nails, where about 6% of the general population has a chronic nail biting habit. 26% bite their lips, their cheeks, their inside of their mouth. So once you have this kind of body-focused repetitive behavior of trichotillomania, you have a lot of the other ones too. When we talk about onset, we have two real ages of onset in the disorder. There's a young kid version of this, sort of an infant trichotillomania, if you will, and that starts between the ages of 18 months and 4 years. Okay. Now this type of trichotillomania, up until some data I'm going to report in a little bit, was believed to be more short-term. It didn't last as long. That's kind of the belief, but there really wasn't much data to support it. It was believed to be more related to attachment. So children, when they start to eat, when they start to feed, they like to stroke soft objects when they're feeding, and if it might happen to be their own hair or their mother's hair when they're eating, they can form an attachment with the hair, and the contact with hair can soothe them, relax them, calm them down. And often it's related to this pulling behavior is related to co-varying oral habits because they're feeding at the same time they're stroking their hair. And so later on, when they get older, and even after they stop breastfeeding, for example, or bottle feeding, when they get stressed or tired, they go right back to the thing that used to calm them down, which was the sucking their fingers and rubbing their hair. And you see that kind of pattern happen to these really young kids. Usually, the belief was that people would grow out of it. Okay, we didn't know that for sure, but I'll report some data in a little bit. The more traditional trichotillomania, the kind you will see here, is usually starting between the ages of 9 and 13. All right? It's right around this onset of puberty time that it really tends to take place. This type of trichotillomania, I think, is a fundamentally different thing than what you're seeing here. This type of trichotillomania is much more difficult in response to treatment. This is easy to knock out. This is hard to knock out. It's a much more chronic condition. Once you get this type of trichotillomania, you pretty much have it. And it bounces. I mean, it goes between pulling and picking, and you might stop pulling for a while, maybe a year or two, and then suddenly flare up again. It might switch to picking, so it kind of keeps going. This is a tough condition to treat. I told you I had some data I wanted to show about onset. Now this is a little bit of a strange graph, but I want you to understand what it is, because it tells you about these young kids and how their pulling does tend to go away. This is the age of the child. We surveyed parents of children with trichotillomania, and we asked them, how old is your child? And at what point, what age did they first start pulling? All right, so that's right here. What you see is if you have a 1-year-old child, obviously 100% of them were starting to pull when they were 1 year. All right, because they're 1 year old. When you have 2-year-olds, if you have 2-year-old childs, 100% of them still started to pull when they were 1 year. Right? When you get to 3-year-olds, you can see about 75% of them were still pulling, or had started to pull when they were birthed to 1, but then another group started to pull when they were 2 to 3, which makes sense. So you keep going, but then what you see out here is, by the time you get to 6-year-olds, very few of them, fewer than 20%, about 15%, had started before they were birthed to 1, at that early age of onset. Most of them had started actually when they were 6 to 7, so recently. Most of them hadn't started much earlier. And by the time you get out to 8, 9, when traditional trichotillomania starts, virtually none of them had started to pull very young. By the time they were 9, the kids who were pulling when they were 9 were just started pulling recently. They weren't these kids who kept going. And so what this tells you is that there really is this sort of bimodal age of onset. These young kids develop early, and it pretty much stays there until about the age of 5. And when the age of 5 hits, they usually they're done with it by then. But then, then a whole different set of problems comes in, a whole different style of trichotillomania comes in. And so there really is this bimodal age of onset. Now, gender distribution. About trichotillomania, we don't know about the young kids, the really young children, but for the 9 and older starting dates, this is pretty much a female disorder for the most part. At least clinically it is. 80% female in children, that's what we found in one of our studies, but that's a self-reporting bias potentially. But when you look at adolescents and adults, you see 70% female in children with trichotillomania, ages 10 to 17, 90% female in adult samples. This is a 7, 8, 9 to 1 kind of condition. 7 to 9 females for every male who gets it, that we think. Now there are questions as to why that gender bias shows up. Is it treatment seeking? Is it that women are more likely to seek treatment for every mental health condition? Could be that. So these are clinical samples and people think that that might be the reason. Is it concealment opportunities? Men can hide this better than women can. If a man pulls a huge patch out of the side of his head, he just shaves his head and then he's cool, everything's good. A woman can't do that. A man who shaves his head, is trying to look tough. A woman who shaves her head is a cancer survivor. I mean, that's really kind of how it's viewed in the society. Men, if they shave their beard, they don't have to worry about picking from their face. So those kinds of things happen. There are standards of beauty. So, a man has a little patch out of his facial hair, nobody cares. It's like whatever. But a woman has some bit missing on her eyebrows or eyelashes or something like that, and there's a standard of beauty that the society holds the woman to that isn't necessarily holding the man to the same standard of beauty. Could cause more impairment, more problem that the woman wants to seek help for. It probably, honestly though, is a real difference, and it's probably some sex-linked causal factor that's really making the difference show up. Adults, when you look at other conditions, now, we always think of, in fact, it's being classified in DSM-5 as an OC spectrum condition, this disorder. But when you really look at the prevalence data, that's probably not right. It's probably its own weird little thing in a lot of ways. It's related to OCD, clearly, but it's not at the prevalence rates, the comorbidity rates aren't as high as you might think. When we look at other conditions, up to 60% of people with trichotillomania have another current disorder. They have something else. What's the most common? The most common is some form of major depression. There are 2 studies that have found that major depression roughly goes at about 28 to 30% of people with trichotillomania. We also know that depression in trichotillomania is probably secondary to the condition. It shows up after trichotillomania does. Okay. Anxiety disorders in general, as a group, happen in about 28%. When you look at the distribution of anxiety disorders, excluding OCD, by the way, GAD happens in about 13%, social phobia in about 11%, specific phobia in about 11%, and PTSD in about 5%. The reason I put PTSD up there is because there's often a belief out in the community that people with trichotillomania must have been sexually abused or had some kind of violent sexual assault, and that's probably not the case. When you see PTSD rates this low, the chances of everybody starting trichotillomania because of some violent sexual assault is probably pretty low as well. OCD, it really hovers right around 11%, 10 to 11% from what we've been able to tell. It's not a 30-40% comorbidity in terms of OCD. In fact, Tourette syndrome has a much higher comorbidity rate for OCD than trichotillomania does, even though trichotillomania is going to be considered part of the OCD spectrum and Tourette's is not. Substance abuse, 2.6%. Impulse control disorders in general, 36%.
Doug, the 2.6 on substance abuse seems incredibly low. Isn't that even lower than what would be in the general population?
Yeah. Hasn't been well studied. I got to say that particular study is a small little characterization, small sample, 40 or 50 patients. But you really don't see much about substance abuse in these folks. I mean, even we did a large community survey of 1,600 people with trichotillomania, and substance abuse problems did not come up. It's really low. It kind of makes me wonder if, and as we talk about this, it might be an either or. Substance you pull instead of using a substance per se. In a lot of ways, I think this is more of an addictive kind of thing than anything. At least elements of it.
So treatment for substance abuse, we could start making them pull their hair.
Well,
that was a joke.
You might be able to treat the pulling with substance abuse treatment.
Yeah. Dennis, that was a joke.
When we look at children, we again see GAD at about 13%, OCD even a little bit lower in children with trichotillomania. and ADHD about 8.7%. And there's a lot less data on children with trichotillomania. Where do people pull from? They pull primarily from their scalp, and this is true for children and adolescents. Next most common places are eyebrows and eyelashes. Those are very common sites. Pubic hair. Obviously, children and adolescents aren't going to pull from the pubic region as much. There's sometimes nothing there to pull, depending on the age. And the important point here is 59% of adults do this from the pubic region. Now, if you first start interviewing these patients, you'll never guess it's that high if you don't know how to ask the right question. If you just go in and start going down a checklist, you pull from your pubic hair, they're going to say no, even though they are. And the way you have to ask this, well, let me back up. We've done face-to-face interviews in the literature, and then there have been anonymous questionnaires. When you ask this face-to-face, you get prevalence rates of pubic hair pulling that are 10, 20%. When you ask them anonymously online, you get 59%. Right? What's the difference? You're staring somebody in the face telling them you're pulling your pubic hair. It's a hard thing to do. It's not an easy event. So what I do when I start asking people clinically, where do you pull from? I basically start out by saying, look, we're going to talk about some embarrassing things. I know, that, for example, pulling pubic hair, people, when we ask them anonymously, a lot of them tell us they do that. When we ask them face-to-face, they get embarrassed and they don't say as much. So I want you to be as honest with me as you can. When I set it up like that, they usually will be honest. And I usually do clinically get about that 60% kind of rate. So basically anywhere there's hair, you can pull. What triggers pulling? The act of pulling itself. You will very rarely, in many cases, see the act of pulling in its entirety. I've been treating this for almost 18 years, and I don't know, except maybe once or twice, that I've ever seen anybody clinically do this, like in front of me. It always happens in private. It's kind of an isolated sort of behavior. People with trichotillomania often engage in a lot of pre-pulling activity. They will start by stroking their hair, searching for a hair. They're isolating a specific hair. Sometimes it has to be the right color, sometimes it has to be the right texture, the right thickness, whatever it might be. Once they find that specific hair, that's when they start the pulling action. There's a lot of preparatory behavior, looking in the mirror, turning on magnifying mirrors, lights, pulling out tweezers, searching for the right hair, those kinds of things. When the pulling happens, it can happen in a lot of different ways. Usually it's just the first two fingers. Sometimes there's wrapping of the hair and then yanking. And then the post-pulling behavior is where it really also gets very interesting. People a lot of times will do many different things with the hair that they pull. They might just sometimes pull a hair and then discard it, not even pay attention to it. But a lot of times they'll do many different things with this particular hair that they pulled. They might manipulate it, so they might run it between their fingers or run it along the ridge of their mouth and kind of get that tickly feeling. They might put it in their mouth and like the feeling of the ridge of the root that goes across their tongue as they put their tongue to the top of their mouth, and they feel that tickling feeling going across their mouth. They can stare at it. Sometimes they like the bloody root. They like to see the root and watch the root. They might eat it. They can sometimes eat the hairs, and if that happens, actually, that's something you need to pay attention to, because that can actually be harmful to them physically. We'll talk about that in a little bit. I had one girl once, she was 16, who her thing was this. She would sit in the evening, she would sit on her bed and she would start to pull her hair. She had to pull hairs until she got the roots. She had to have particular types of roots, big, bloody, juicy roots. She would pull until she got enough big, bloody, juicy roots. There wasn't a magic number or anything like that. She just had to have enough of them. She would pull the hair, she would get the right root, she would pop off the root, she would take the root, put it on her nightstand, not a nightstand, but the backboard, headboard. She would put it on the headboard, and then she would discard the hair. She could care less about the hair itself. She wanted the root. She would do that until she got, 10, 15 roots up here that are all bloody and sticky and now sticking on the headboard. She'd be done. She'd come back the next day, chew them, and then begin again. That was her routine. That was what she wanted to do. And over and over and over and over again. It's a lot more complicated than simply just going like this all day. So there was a whole scenario involved there. Now, we also know that various unpleasant emotional states have been found to trigger pulling and are often reduced during a pulling episode. So people feel more stressed, more anxious, not all of them, more depressed, sad, upset. They go into pulling, and while they're pulling, they feel this kind of calmness. We know biologically repetitive action can bring down stress. That's just kind of a physiological response. When you start doing something over and over again, physiologically you get less stressed. So these people go into this, they start relaxing themselves, so to speak, de-stressing, getting their mind off of these thoughts, and then once they're done pulling, or once they kind of come out of it, they start feeling very guilty and bad that they've done this, but for a while there is some brief relief, yeah.
What about pulling other people's hair? My niece pulled her younger sister's
Yeah.
hair. Is that?
It happens. I mean, yeah, it's not just your own hair. I mean, that's mostly what it is, but I've had cases where, you know, very patient spouses have sat there and let their wives pull their back hair or head hair. I mean, it's, you know, it's very primal, if you will. I mean, if you think of a grooming behavior from a chimpanzee or something, it's very much like that. It's not as social as their action is. I've treated patients with bald pets, like the family dog has bald patches brought on by the patient. So you get all kinds of things, basically anything with covering. I've had children with trichotillomania who have denuded Barbies. They've had Barbie had all her hair pulled out, or dolls that have come out with no hair. So a lot, it's not just your own hair, but that's typically what it is. And I don't think we accounted for that in DSM-5. Barbie's got a bald patch, and you don't. Does that count? I'm not sure. They really seem to go back and work on those criteria.
Yeah. Separate category.
Right, by proxy or trichotillomania by proxy. Two distinct styles of pulling. We're going to talk a little bit about that because that'll set up our model. When people pull, there really seem to be two distinct styles that they pull in. That most people have both styles. They demonstrate both styles at different times, but they really do seem to be two distinct styles. Factor analytically, they're distinct styles, and phenomenologically, there's distinct styles. And what you see are one style is called what we've called automatic pulling. This is what we think of as habitual, out of awareness pulling, right? At least when it starts. This is the type of pulling where the person is sitting there at night on the couch watching television, and they're just going to town. They don't even know they're doing it. The show ends, they're like, oh, I've been pulling, I didn't even know I was doing it. Or they're driving in the car, thinking, and they're pulling, and then they look down and there's a pile of hair in their lap, and they're like, where did this come from? It's that style of pulling. It's really not related to any emotional state except maybe boredom, or kind of down physical time. And they're just not aware that they're doing it. Yeah.
Have you seen it when people are intensely focusing on other things? I had a student do it during tests taking.
That would be another example of this. Just not even aware that they're doing it. Okay. In fact, there are a few people in here doing it right now and they don't even know they're doing it. I get this perspective. Now you may become aware of this kind of pulling episode after it started, but and you may choose to continue, but it's still considered like an automatic style of pulling. This isn't a conscious choice. This is something that just happens habitually. And it's likely maintained by some sort of sensory stimulation. Right? It's likely maintained by the tactile sensation of the fingers on the hair, or the brushing that you feel on your scalp, or the feeling on your lips, or whatever you're doing with the hair afterwards. It's probably maintained by something like that. Some very basic level of tactile reinforcer. The other style of pulling, though, is a little more troubling. And the other style of pulling is what we call focused pulling. Focused pulling is really pulling with a more conscious choice. All right? You're choosing to pull. So it would look something like this. My boss has been on me all day. My husband and I are fighting. My friends are mad at me for some reason. And I'm having a really bad day. I'm really stressed. I can't wait to get home so I can go to the bathroom. I can't wait. And all this stress, anxiety, emotional roiling that's going on inside. She gets home, she goes to the bathroom, locks the door, flips on the lights, turns on the magnifying mirror, puts on the side lights on the mirror, pulls out the tweezers from her case down in the third drawer, and then she goes to town. And 2 hours later, she comes out with no lower eyelashes. That's focus pulling. Now, while that's going on, she's it's bringing her down. She's getting less stressed while the action is going on. She's getting less emotional during that time. Now, after she's done, she's going to look at it, she's going to feel crushing guilt because of what she's done to herself yet again. But while it's happening, that reduction in emotion is intense and it's powerful for her. So what we think of is that this type of pulling is reinforced by avoidance of or escape from some kind of unpleasant private experience. A strong urge to do it, for example, they feel this real, I've got to do it. They pull, and what's the reinforcer for that? The urge gets reduced. The thought, this hair's out of place, this ugly gray hair, I can't stand the look of this. They pull, that thought goes away. They feel anxious, stressed, upset. They pull, and while it's happening, that urge or that anxiety, stress is reduced. It's always replaced with some other negative emotion, which creates a vicious cycle, which is why people keep pulling. But in the short term, it actually happens. Now, I'm going to take a step back because I want to explain this construct so it makes sense of why we do the therapy that we do. If you have these factors that are triggering your pulling, urges, thoughts, anxiety, one very legitimate way, except maybe with urges, one very legitimate way to try to treat pulling of this style, of this focus style, is to try to eliminate the triggers. Try to eliminate anxiety so they don't feel anxious, so they don't have to pull. Change their thoughts when they look at something so they don't think of things in a certain way, they think of them in another way, which should reduce the likelihood that they'll pull, and try to reduce the urges to do the pulling, which that's a little harder, but you try to reduce the pulling urges. So that's one legitimate way, and traditional CBT kind of focuses in that way. That's how we think of it. Let's reduce the triggers and the behavior will not show up. And that's perfectly legitimate. But there's another thing to think about, and the question is, and this is going to get a little theoretical for a second, I'll try not to stay on this too long, but the question is, why do we have to get rid of those things in the first place? Why do we have to not have anxiety in order to not pull? Why do we have to have a reduction in a thought or an elimination of a thought in order to not pull? Why can't we be anxious and refuse to pull? Why can't we have a thought that hair doesn't look right and still refuse to pull? Why can't we have an urge to do something but not act on it? You know, why is it that we think that we have to reduce these things before the behavior can be reduced as well? Okay. Well, that goes back to this other construct, this construct of experiential avoidance. This is something that Steve Hayes talked about. It's not necessarily a new construct. People have talked about this for years. But Hayes talks about this idea that people who have, that there's this construct called experiential avoidance. It's a behavioral construct. In other words, it's a behavioral repertoire people have. People can have a lot of experientially avoidant behavior, or they can be very low in experiential avoidance. In other words, not demonstrate much experiential avoidance. The idea of experiential avoidance is some people, given their learning history, are going to really not want to be in contact with unpleasant private experiences like thoughts, images, urges, those kinds of things inside our skin. And the more avoidant we are on those things, the more we're going to do, in other words, the greater history we've had of wanting to get away from those things, the more likely we're going to be to do things that get rid of unpleasant experiences when they appear. If we're high in experiential avoidance, we'll do whatever it takes when we have a bad feeling inside of us to get rid of that bad feeling. Maybe it's drinking, maybe it's drug use, maybe it's eating, maybe it's washing, maybe it's checking, maybe it's pulling, maybe it's whatever, maybe it's running. But we'll do whatever we can when we feel bad things inside of us to get rid of it. That's a person who's high in experiential avoidance. Okay? They get high in experiential avoidance because of a certain upbringing, is the theory. People who are low in experiential avoidance are people who have a tendency, when they experience unpleasant private experiences, to say, yeah, I don't feel well right now, but I'm still going to go out and do what I need to do. Or yeah, I'm a little nervous, but I'm still going to stand up here and give this talk. I mean, yeah, I have this feeling, but so what? I don't like it, but I'm not going to do anything to get rid of it. It's just here. It's part of who I am. So that's kind of a continuum. Hayes' theory is that people who are high in experiential avoidance are more likely to do these kinds of things, these emotional escape behaviors, if you will. And interestingly, what we found is experiential avoidance is a measure of experiential avoidance, has been correlated significantly with trichotillomania severity. So the people who are higher in experiential avoidance, those people who don't like to be in contact with unpleasant private experiences and do whatever they can to get rid of it, are more likely to pull. In particular, they're more likely to do focused pulling, not just pulling in general, but that emotion control type of pulling.
Doug, are they more
Yeah.
likely to pull, or if they pull, it's more severe?
Pull is more severe, because this was a group of people with trichotillomania. So yeah, that's a good important point. We did another study, actually one of the people who worked out here, one of my graduate students, Melissa Norberg, and I did this study a while ago. And we did an interesting study. We looked at correlations between cognitions and pulling severity, different cognitive constructs and pulling severity. And what we found was fear of negative evaluation, feelings of shame, and negative beliefs about appearance all correlated, not strongly, but significantly with hair pulling severity. This is the hair pulling severity scale. So when you have concerns that other people are evaluating you negatively, your pulling will be higher. When you feel feelings of shame, your pulling will be stronger. And when you have negative beliefs about your appearance, your pulling will be stronger. All these kinds of normal cognitive things. But we did something else too. We then took out all the variants associated with experiential avoidance. So we said, let's assume that everybody is the same on how much experiential avoidance they have. Let's take out anything to do with this history of wanting to suppress or control your emotions. And when we did that, these relationships between these cognitive emotional variables and pulling disappeared. So what we took from this was that, yeah, there are relationships between emotional experiences, cognitive experiences, and pulling, but the glue that holds those two things together, cognition and the pulling, is actually a broader variable of what we call experiential avoidance. This general tendency to not want to be in contact with unpleasant experiences. So what that tells you from a model is you've got a couple different ways you can go at this. Yeah, you can target these cognitions, you can target these emotions directly, that's not a bad thing. But you can also try to go after the whole context that they bring into this whole general history that they have of trying to avoid and escape from unpleasant experiences. If you do that, these links fall apart between pulling and cognition. That's the idea. That's an important thing because it'll talk about the basis for why we do what we do. Let's see. Physical impact of trichotillomania. There are a few pieces to think about when you think about physical impact. One is baldness, obviously. It's kind of written into the criteria. You lose hair. Other things you might not think of. Dental problems can occur. You get people who will pull the hair and then run it through their teeth like this. Hair is a very strong substance. It's probably tensile strength is as strong as steel when you really think about it. It's just so thin you can break it. But it's a really strong substance. And when you start running this through your teeth, you can cut grooves in your teeth actually. So you can check for those kinds of things. You'll get bleeding of the scalp. You'll see that. One thing people don't think about, but you get repetitive strain injuries, like carpal tunnel syndrome from continually going like this, those kinds of things. The big concern physically is something called a trichobezoar. Trichobezoar is essentially a hairball. And what happens is when people with trichotillomania eat their hair, it's not super common, but it does happen. The hair goes into the stomach, and the stomach is think of it like a funnel. So there's a tube opening at the end, and the stomach sitting there. The hair, if it's eaten fast enough, drops down into the stomach and forms like a net over the exit of the stomach. And as you eat and consume stuff, it packs in there more and more and more and more and more and more. And basically, if hair and food continue to pull in there, during the pulling, it just fills and fills and fills and fills, and you end up with something that looks like that, which is a trichobezoar. Okay, this is the stomach. This is something that's been removed from somebody. This is the stomach, and that is the intestine. Not really the intestine, it's like a cast of the intestine, which is all that is hair and food matter that hasn't been able to digest. So you get these kinds of things. When that happens, you can get malnourishment, you can get severe stomach pains, and it could potentially lead to death, although I don't know if there's any documented cases of this because it usually gets caught because of the horrible stomach pains before it actually leads to that, or severe malnourishment, fatigue. So if you have a patient that comes in who admits to pulling their hair, or if you have an adolescent, for example, who obviously has no hair, but the parent can find none of it, like can't find it in trash cans, can't find it on the floor, can't find it anywhere around, you need to look at this. If they feel, if there's a lot of fatigue, if there's a lot of weakness, if there's stomach cramps, if their appetite's not very good, think about this and just get this checked because it could be happening. Another big thing of negative physical effects is people with trichotillomania avoid going to the doctor. They don't want to be seen. You know, they don't want to get caught. They don't want to be found out. So that can be another negative physical impact of the disorder. In children, kind of the psychosocial impact, 56% of children in our child and adolescent trichotillomania survey reported avoiding social events of some sort because of pulling. 55% reported that the pulling behavior made it more difficult to study. 36% said their academic success was impaired. 80% felt that the pulling actually led to some other psychiatric condition as a result of that behavior. Those were parents' reports of the children. When we look at adults, adults report moderate interference, home management tasks, social lives, and ability to maintain close relationships. 20% have avoided vacations, 40% avoid social events, and 36% avoided some other kind of social or other group activity. 23% reported some kind of daily interference with job duties. When you look at academic success, like college students, 76% report difficulty with studying because of pulling, and kids miss roughly 9 days of school per year due to pulling when they have this. When you ask adults, do you think your pulling has led to some other psychiatric condition? About 70% say yes. When you look at how anxious and stressed this group is compared to OCD folks and the typical population, what you see on the depression, anxiety, and stress scale is that these folks are every bit as depressed, anxious, and stressed as people with full-blown OCD. And both of them are much more anxious, depressed, and stressed than typical controls. So concluding about trichotillomania, it's not a rare disorder relative to other psychiatric conditions. It affects all age groups, affects primarily females, associated with significant comorbidity and impairment, and it's still in its infancy in terms of research. We don't know a lot about this condition yet. My grant and Marty Franklin's grants were the first 2 grants ever to be funded by NIH on trichotillomania in the history of the Institute. So it's really just starting in its infancy. Okay. Let's talk a little bit about treatment of trichotillomania now. What do we do from the model? We talked about automatic and focused pulling. We think automatic pulling is maintained by these visual, tactile cues, and we think that the consequences of pleasurable sensations from the tactile experience and the kind of the rush they might get from that are reinforcing the automatic pulling. And the focused pulling, we think, is really maintained primarily by this affect regulation experience that people have. So what we try to do is we use functional analytic procedures to try to develop effective interventions. We try to identify what are the triggers for the pulling, what are the tactile cues, the affective cues that they have, the environmental cues that they have, and we then try to change their environment as much as we can. So for example, if they are pulling in front of bright mirrors with bright lights and tweezers, we might have them throw their tweezers away. We might have them take out the light bulbs in their bathrooms for a short period of time, cover mirrors, get rid of magnifying mirrors, those kinds of things to restrict the opportunity that they're going to have to trigger the pulling. We might have them make sure that they're groomed in a certain way on a regular basis, so they get their once-a-week haircut so hairs don't get out of place that trigger the pulling episode, those kinds of things. We might have them set a timer in the bathroom so they can't be in the bathroom for any more than 2 minutes, 3 minutes, for example. We might have them, if they pull in bed at night, that's a pretty common thing, we might have them keep their door open, or sometimes we'll ask parents to take the door off the hinges so the kid can't close it, and it kind of puts some stimulus control over the behavior. So we'll identify the specific factors that trigger the pulling, and then we will try to change those factors in a systematic way. Okay. So we talk a little bit about what we do. Automatic pulling, we identify the antecedents that trigger pulling, heighten awareness of the pulling episode, provide strategies to stop the behavior when it's recognized. Remember, the whole point of automatic pulling is this autopilot sort of pulling that they're doing. So our goal is to limit the likelihood that it's going to start in the first place, and then because they're not aware of it, make them more aware of the action, and then give them something to do to stop it when they've started. Okay? And so what we're doing there is habit reversal and stimulus control procedures. We'll talk about those a little bit. Focused pulling, what we're trying to do is to train skills that cope with or reduce the aversive urges that they experience, or changing the cognitions. That's if we're doing traditional CBT, but we can also do it a different way where we target this general context that goes after what we call experiential avoidance. We'll talk more about that as well.
And Doug, you were mentioning that most people have both, so I'm
Yeah.
assuming that you're doing a blend of,
Yeah.
of those two things.
We do. That's what we'll talk about. When we do the core elements of treatment, what we do is psychoeducation, self-monitoring awareness training, stimulus control. And stimulus control is, again, identifying those factors that trigger the pulling and changing them in the environment so their pulling's not as likely to start in the first place. And also trying to identify any tactile stimulation that the pulling gives and give replacement stimulation. So, for example, carrying kids like the feeling on their hand of the hair. So we might give them koosh balls or squeeze toys or something that they can, like stringy kinds of things, that they can have in different locations where they're most likely to pull. They're instructed when you go into that situation, the first thing you do is pick that up. And that'll give you that tactile stimulation, but you won't have to pull to get it. We do competing response or habit reversal training, which teaches people to be more aware of their pulling and when it's about to start. And when they start pulling, they're instructed and taught how to do some other behavior that physically prevents the pulling, like making a fist and holding it at your side for a minute. We also, in treatment, these things, by the way, are the automatic pulling treatments. These things are more for the focused pulling. When we address those internal antecedent and affective regulation functions, what we're trying to do, at least in children, we teach them relaxation and stress management, and we do cognitive restructuring if we need to regarding cognitive triggers to pulling. And then in adults, we really move to an acceptance-based model, teaching people that they don't have to try to control their emotions. They have to learn how to accept their emotions, yet behave in a way that's different than what their emotions are telling them to do. Examples of stimulus control: we identify high-risk situations, modify the discriminative cues. So, for example, like I said, keeping the bathroom door open while grooming, or taking the door off of the hinges in the bedroom, for example. Another thing we find that if people are doing this a lot while they're watching television, posture makes a big difference. Posture can be a discriminative cue. So, a kid says, "Yeah, I pull a lot while I watch TV." My first question is, "How do you watch TV?" They're like, "What do you mean, how do I watch TV?" "Where do you sit?" "On the couch." "Which side of the couch?" "The right side." "Well, how do you pull?" "Which hand do you use?" "My right hand." "Show me." Where's your right arm when you're sitting on the right side of the couch?" "On the armrest." "Do you think maybe that's a little too close?" "I want you to move one seat over and sit in the middle of the couch." And just doing that a lot of times can reduce this automatic pulling dramatically. Just simple structural changes to how they do things. And so, we really want to get very detailed about the discriminative cues. What's going on exactly when they're doing this automatic pulling? What settings are they in? What could potentially be triggering this? We want to modify, like I said, the interoceptive cues. So if they pull a lot at night, we think that they're good tactile stimulation on their hands that's really getting it going. We might give them gloves, wear mittens at night, kind of thing. Not all the time, but in a high-risk situation. Maybe we want to put those little rubber finger caps on a couple fingers where they manipulate the hair a lot. Make it harder for them to get the hair in the first place. Now, we don't want to do that forever. This is a short-term thing to sort of break the habit, but it's one of those things you can do initially. Like I said, we provide alternative options for the tactile reinforcement. Also, to treat automatic pulling, we'll do what we call habit reversal training. And I'll talk a lot more about this when I talk about tics, so I'm not going to go into much detail, but essentially we teach them to be more aware of when they're pulling and about to pull. People with trichotillomania will never pull in front of you, but my God, they'll do a lot of this. And every time that hand goes up, that's a trigger that they could potentially be pulling. And they're not aware at all of how often their hand is going to their head. And the first thing that you have to do therapeutically is to teach them every time their hand's apart. Oh, there it is. There it is. There it is. See, it's up there a lot, isn't it? And they start to become aware. It's like, wow, I had no idea that this was happening so much. After we teach them to be more aware of that pulling and pre-pulling action, we then teach them to engage in a competing behavior. We teach them to do something that physically prevents that action from continuing. Most cases is just gently make a fist and hold your hand down at your side for a minute. And do that action every time your hand starts to go up to your head. And what that does is start to build in some kind of inhibition. They start to notice and their hand goes down, start to notice and their hand goes down, and it becomes a new pattern. It's not an easy pattern to initiate, but when it's there, it can be very effective, at least in reducing the automatic pulling. Now, we also have a social support, at least in kids this is important, where you have the parent remind the child frequently to use the competing exercise. So when they see the child's hand going up and then the competing response happening, the parent's told to praise the child. They see the child's hand go up and then not use the competing response, the parent's supposed to remind the child to use it. In adults, it doesn't really add much, so we don't actually worry too much about it in adults. Now, in terms of the focused pulling, what we do is we deal more with this acceptance-based treatment for dealing with focused pulling. Remember, we talked about this idea of experiential avoidance. How do you go after this general history people have of not wanting to be in contact with unpleasant private experiences? How do you go after that? Well, first of all, I think you kind of have to understand that there is a payoff for getting rid of these unpleasant private experiences. People who are very experiential avoidant, they feel uncomfortable, they feel very unhappy, they pull, they get this automatic relief from that bad feeling. So you've got to give them a reason, a reinforcer, so to speak, of why they should do anything different. Okay? Now, people with trichotillomania can tell you what problems pulling causes. I mean, that's why they're in therapy. Anybody who comes to therapy can tell you why they want help. At least most people can. But there's a difference between that and really making it clear for them why they want help. Because in the situation where they're about ready to pull, they've had the stressful day, they feel awful, and their hand's going up to their head, they need to know very clearly what the contingencies are. If I pull, I'm going to get relief temporarily. That won't last. If I don't pull, I'm going to have to put up with this horrible feeling, but the reinforcer's down the road. And they need to know what that reinforcer is, and they need to be able to say it and see it right in that moment that they're making that decision to put their hand down. So what we do first, before even talking about experiential avoidance, is clarify their values. We say, what is it that you want to get out of this? What do you want to be about? Who do you know, what do you want to stand for as a person? At your core, what is it? And so we use exercises to try to clarify for them what it is that's really motivating for them. And it's not just looking good. That's a shallow reason. I mean, it really is. It's not just so I have a full head of hair. That's not it. It's got to be bigger than that. And so one of the things we do is we use something called the tombstone exercise. We got this from Hayes, essentially. Writing your epitaph, so to speak. So we give them a workbook and we say, okay, imagine you die tomorrow. What do you want people to say about you? One sentence. What do you want to be known for? You know, write your epitaph. And that's actually a really powerful move when you can do that and you have a patient really take it seriously to think, what do I want to be known for? What do you want to be about? They always say something like, I want to be a good person. I want to be a good parent. I want to be there for my family. I want to, you know, there's something social usually that comes up, some interpersonal contact. And sometimes they won't understand this at first. They'll say something like, I don't know, I really want to have, you know, my hair back. Okay, so when we go to your graveyard and we see gravestone and we see on your gravestone, here lies, you know, Alice. She had a full set of hair. Is that really what? And then they start laughing. It's like, of course, that's not what I want to say. Okay. How about, well, I just don't want to feel bad anymore. Okay, here lies Alice. She didn't feel bad anymore. Is that really what you want on there? Well, no. And then usually, by the time you do this enough, it goes back to, I want to be a good mom. I want to be a good wife. I want to be a good, you know, daughter. I want to be a good whatever it is. And that's when you get to that connection, then you have something. Because in that pulling moment, you can go to them. When their hand's up there, you can remind them. They should be reminding themselves, okay, my choice is this. I choose to put my hand down, or I choose to keep my hand up and start pulling, and I'm going to go into this pulling for 20 minutes, and that's 20 minutes that I'm not being a good mom, that I'm not spending with my child, that I'm not spending talking to my mom or my dad or my whatever it is. That's 20 minutes I'm not doing that. And the reason I'm not doing that is because I don't want to feel bad. You know? Or I can put my hand down and yeah, I'm going to have to feel bad, but I'm feeling bad, so I can be a good mom, I can be a good daughter, I can be a good wife, that kind of thing. And if that connects for them, if you really understand their values, that can be a very powerful motivator for them. Because what they're going to be doing is going against their programming. Their programming is always told them, don't feel bad, do whatever you can to not feel bad. And so we've got to give them something that's more powerful than that. Right? We also then talk with them about what it is that's keeping them from accomplishing their values fully. What is it that's keeping them from being the best mom they can be? What is it that's keeping them from being the best daughter they can be? What is it that's keeping them from being the best person they can be? And a lot of times they'll say, oh, it's my hair pulling. And we'll say, well, not really. You know, hair pulling is just doing something for you. What is it doing? And we start uncovering for them that it's really controlling these negative emotions. And pulling isn't the only thing they do to control their negative emotions. They do a lot of other things to control their negative emotions too. They walk out of discussions with their spouse because they feel bad, or they want to avoid talking about certain topics because it makes them upset, or they want to not go for that job advancement that they could because they're scared of what their boss might say, or they don't want to go back to school because they're scared they might fail. There's all these emotions that they're controlling constantly, but it's always costing them. And we want to show them, we're trying to uncover that for them, that pulling is just one thing. It's just one thing that you're doing, but you're doing a whole lot of other stuff that's costing you in terms of being who you really want to be. And so then after we kind of set that up, that the problem isn't really pulling for them, the problem is really that they can't stand having unpleasant emotions. They feel like they're stuck. They can't move forward until they get over these unpleasant emotions. Once we get them to see that, then we have them start to think about how useful it is to try to control these internal experiences. How has this worked for you? Let's just be pragmatic. You know, you get anxious, you get stressed, you get upset, and you try to control them through pulling in other ways too. Do you still get anxious, stressed, or upset? Yeah. Would you say you're actually getting more anxious, upset, and stressed now than you were 10 years ago? Well, yeah, probably am. Yet you're still trying to do the same thing over and over again. You're still trying to control this stuff in ways that clearly aren't paying off because you're getting worse. You know, why would you keep doing that? And you're trying to get them to the point where they see that this emotion control stuff that they do, pulling is just one thing, but this emotion control stuff they do works in the short term for them, but it doesn't work in the long term, and it ends up costing them in terms of their values. So you really want to get them to see that what they're doing just doesn't work anymore. And once they see it in that way, then they're usually at the point where they say, well, what do I do? You know, what am I supposed to do? And that's where once you get that in, you can offer this idea of acceptance. Yeah, you're right. You're probably not going to be able to get rid of these things per se. Maybe a different way to look at it is instead of trying to get rid of urges, thoughts, emotional experiences, maybe a different way to look at it is, you know, urges, thoughts, emotional experiences are actually just part of being normal. We all have those things, and they're dictated by what happens around us. Maybe instead of trying to stop them all the time and work against nature, what you do is just allow them to be there, but not let them control what you do. That's your choice, is to let them control what you do. And so then we start talking about diffusion exercises, getting people to see that the thoughts, images, urges that they have aren't real things. They're not things that have to control your behavior. It's a choice whether emotions, thoughts, or images, or urges control your behavior. It's not a foregone conclusion that if a thought is there, you will respond in a certain way. That's your choice once you realize you have it. And so we use a lot of different exercises to try to show people that thoughts, urges, images are nothing more than mental phenomena that you choose to react to or you don't. And I'll do something like this. I'll say, so you tell me that when you have this thought, I have this really thick gray hair that I have to pull. That makes you pull when you see that thick gray hair up there and you have the thought that shouldn't be in there. You tell me that makes you pull, right? Patient says, yeah. And I'll start asking them, can I pick on you for a little bit?
Sure.
Okay. I'll say something like this. I'll say, so you're telling me that thoughts cause you to do this behavior. They make you pull. What is a thought? And I'll ask the patient, what's a thought?
And that pops into my mind.
Okay, something that pops into my mind. How many of you are CBT trained folks here? What is a thought? Because you're changing them. A cognition, you're changing that all the time. But what is it?
of like Tim's answer, actually.
Something that pops into your head. What's it made of? Because it's a basic physics question, and I mean this seriously. If something's going to make you do something, there's got to be a physical basis for it. I mean, purely physics. There's got to be a physical basis for making you do something. So what is a thought?
A couple of neural connections.
Couple neural connections?
Like,
So is that what you're changing when you do cognitive retraining, cognitive restructuring?
sure,
On a one-to-one basis, though?
with electric instruments.
You see what I'm saying? This isn't that clear. What are you doing when you're doing cognitive restructuring? You're doing what? I mean, like physically, what are you doing? You're talking, right? Now, there are associations between particular neural patterns and talking. That's true. But you're not modifying directly the neural connections, right? But what is a thought then, phenomenologically, as we're treating it? It's internal language. What is language? Words, right? Okay. So really what we're saying is that words cause you to do something, right? These words, if I have a gray hair, I have a thick hair, I can't stand this, I must pull. So let me ask you to do a very simple exercise. If thoughts can control behavior and thoughts are made of words, then use words to get me to do something. All right? And here's what I want you to do. I want you to use words to get me to walk.
Lift up your left foot and move forward.
Keep trying.
Fire.
Keep trying. And patients do this exact same thing. They always ask me to move my foot first, then they yell fire, and then, you know, seriously, it's like this every single time. But pretty soon, if I keep pushing them, I'm like, come on, you're telling me it's making you go bald. Let's go, let's do something. You're telling me it's making your hand go up. Come on. I push them and they just keep going and going and going, and I don't move. And then they say, I can't. I say, why can't you? And the response is, because you don't want to move. You choose not to move. You choose not to listen to me. It's exactly right, and you can choose not to listen to yourself. And that's how we try to get them to separate that this is a choice. It's not a foregone conclusion that you will react to internal stimuli. Okay. I do another example too. Can I have another volunteer? All right. Come on up. Okay. So we do another example of an exercise. It's called taking your mind for a walk. All right. And the
Short walk.
yeah. Don't have much room either. So, I'm gonna be your mind, Brad. All right. I'm gonna say things that your mind says. I'm just gonna be your mind. Okay. You do what comes naturally to you. Okay. But just slowly walk, and I'm just
So
gonna
I'm
be your
supposed to be
mind.
listening to your mind.
I'm just your mind. All right.
Yeah.
Go ahead and walk. Hey, look to the right. Look at the computer. See what's on there. Look at that red. What does that say? ThinkPad? Okay, this is really stupid up here. This is silly. Yeah, I just keep going. Let's go to the left. No, stop. Oh, look at that shadow. My belt buckle showing her the shadow. How about that? Oh, I wonder what's under the podium. Oh, there's a brown marker. Maybe I should pick up that marker. Open the cap. Sniff it. Just kidding. This is so silly. That's silly. Just keep going, keep walking. I feel really embarrassed now. Oh, look to the left. Yeah. Okay. Okay, you can stop now for a second. What did you feel when I was doing that?
That I probably am low in experiential avoidance, I think.
When I said to do something,
Yeah.
did you feel a pull to do it?
Yes.
Yeah. Okay. And you just kind of followed along, right? I didn't tell him to follow what I said, did I?
No.
I
It was kind of natural because we tend to do what we're told.
Okay, now come over here again.
Yeah. Now, if you tell me to pull my fly down,
Believe me, I won't. So now I want you to go to the phone and pick it up, and I'm going to be your mind. Don't listen to your mind.
okay, don't listen.
But no. You're listening to me. Don't do that, sorry. Go ahead. You really seriously can start. But no, wait, I'm screwed up. You did it again. You can't listen to me. I'm your mind.
I feel like you're just punch it.
Mine's a dark place.
Before, I'm not mine now.
You're not mine. You're Doug.
Go ahead. That way.
Okay.
Now I'm your mind.
Now you're my mind.
Stop. You did it again, Brad. Stop. You're listening to
My
me.
mind is so This is what I deal with day to day.
I'm not your mind.
No.
Okay. Start walking. Now I'm your mind. But don't walk now. Stop. No, seriously. I'm kidding. Stop. No, you did it again.
Could I have security?
It's not an easy thing to do. But that's your mind is constantly going at you all day like that. Don't do this, do that, do this. Don't feel anxious, don't feel stressed. Blah 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 blah. And what we do in therapy is to get that kind of thing going. We get them to practice. My mind's screaming at me. Don't do this. Go this way. Don't feel anxious. You got to stop it. You're feeling stressed. And we've got to teach the patient to disconnect from that. And this is an example of that. And you know what? He's going to sit there and he's going to, almost everybody who does this exercise does the exact same thing. No, stop. Even they know they're not supposed to, but they do because that's what they've been programmed to do. They've been programmed to listen to what's in here, programmed to react to what's in here, but they don't have to. And there's a certain feeling that you get once you start realizing that you don't have to listen to it. You can just go. You do what you want to do. And that's an example, that's a physical metaphor for what going for your values means. I know I'm going to be a good mom, and my child is sitting over there wanting to play with me. So I'm having a bad day, and I'm carrying that with me. It sucks. I really want to get rid of it. I really want to pull. I'm having this bad urge to play, and I'm going to sit down and play with my kid. Even if I'm not 100% there, and I'm still, this stuff keeps coming in, I'm going to make the act. I'm going to physically keep trying to do this, carrying that unpleasantness with me. It's like me yelling stop the entire time you're walking, but you're still going over to pick up that phone. That's really what we try to do when we start talking about diffusion and getting them to understand that their cognitions, their emotions, their urges don't have to control what they do. It's a choice. Right.
Doug, you talked before about how people with trichotillomania report as much distress as people with OCD. And we talked about how the depression is kind of secondary to their pull.
Yeah.
So obviously this kind of gets into a vicious cycle where they have these negative moods, they have high experiential avoidance, but then they pull, they get guilt, which is a negative mood, which they then want to avoid, and it just becomes this vicious cycle. But do you feel that people with trichotillomania have more stress in their life other than what is a byproduct of their pulling? Anecdotally, I believe in the trichotillomania patients we see here that there's, especially in the kids, let's just say, there's always seems to be something kind of going wrong. I mean, there's just some chaos or some problem there, whether it's divorced parents or dad's either there but not really there or not there. Maybe
No, I think that's true. I think they probably do have more of those kinds of things going on. I mean, the classic parent dyad of a kid with trichotillomania, in my opinion, it's not been documented, but I've seen a lot of it, dad is absent, usually relatively a high-powered kind of go-getter kind of guy, but has nothing to do with the family. He kind of sits there and looks at his iPod while the mom's talking about this, sort of disengaged. And then the mother is usually a little hyper-anxious and very critical. Not always, but that's kind of the feeling I get a lot of times. So this kid there's a lot of perfectionistic expectations on the kid from the mother. Not a lot of emotional support anywhere for when stress does come up, so they don't learn how to deal with it in any healthy way. So, yeah.
So as you've been talking, it's just, I mean, it's not the same diagnostically, but as a symptom, it is cutting just seems to be so similar in terms of the overall kind of discussion of how there's some kind of sense of like, I must do this, there's a relief afterward, there's a hiding of the behavior. So I just wonder if you've looked at that at all. I don't think it happens in the same population.
It doesn't. They're very different different in a lot of ways in terms of, my impression, we don't see a lot of cutters that come in with trichotillomania. It's rare,
No, I don't think
actually.
it's the same
Yeah.
population, but it seems to be behaviorally similar.
My impression of cutters a lot of times is that they're cutting to feel something. You know, where the pullers, they're feeling bad. I mean, I know cutters do that too, but they're pulling to kind of reduce in the short term the emotion. But the cutters, a lot of times that I've seen, seem to be more cutting to feel. Yeah. So. But no, I agree. There's this motion regulation component that's underlying both. Yeah.
Should you ever do exposures for trichotillomania, like hold your hand to your hair and don't pull?
You can do it. Frankly, I haven't had a lot of success seeing that. But sometimes we use versions of that, but we use it so that they can watch what happens to their emotions and watch we kind of use it as a sort of almost a mindfulness exercise. So they put their hands there and they say, no, let's watch the urge. Let's show you that you don't have to react to it. And so we're not looking for necessarily the urge to go down. We don't really care. We just want them to watch what happens to the urge. Now, is that a core component of what we do? No, but we do use versions of what might look like exposure.
So that they won't habituate the urge by sitting like this.
Will
they
it go
see
down?
Yeah.
Sure, it could go down. I mean, yeah, I suppose it could.
What Katie's referring to, Doug, is kind of the model that we have used for the most part, in particular used before their students kind of came out and helped us with this. But I would say that it's still been somewhat of a blend, and I think it kind of comes out of the whole OCD world that we live in. And the idea is, you know, for example, you were talking about all of the kind of stimulus control things that you can do with reducing the amount of time in the bathroom and so forth. And you know, in the OCD world, of course, that starts to smack of avoidance.
Right.
And clearly, I think, and Katie, you and I talked about this the other day, you know, clearly you do whatever you can to kind of reduce and then stop the pulling.
Yeah.
But then once a patient has some management of that, then, you know, you ultimately need to be, of course, to be able to be in the bathroom for more than 2 minutes, kind of idea. You have to not have the mirrors covered.
Right.
And so I think that that's where we kind of plug that in a little bit more on the back end.
Yeah.
You know, go back to sit in your favorite spot in the couch, ultimately, assuming you can handle it.
Right, no, absolutely. Well, the other piece in that is what's automatic and what's focused. You know, so the way we structure our group is we always go after automatic pulling first. So we do the stimulus control stuff, we do the habit reversal. We usually see a dramatic reduction in the pulling very quickly if they have both kinds. But then what you start to see is you start to see a little more distress and a little more, you know, non-compliance with the habit reversal piece, because what that really is the focus pulling sort of creeping back. And that's when we start dealing with this emotion regulation stuff. Now, like the traditional exposures kinds of things that you do, I mean, we do that, but we don't frame it in the way that you would frame it in an exposure. So in an exposure, you would say something like, we're going to put this up here so you feel the urge, and what you're going to learn over time is that the urge will go away. You know, and if you do that enough, it won't come back. Or you'll learn that it'll go away very quickly. That's all well and good. That's the traditional model of doing it, though. You know, get rid of the anxiety, you won't pull. And nothing wrong with that. The problem, from my perspective, though, is that it doesn't target the whole broader context of why do you have to get rid of that to do anything in the first place. You know, it doesn't target that experiential avoidance construct. So what we might do is do something that looks very much the same, but we're going to say, look, you can sit there and have this stuff all day, and you don't have to actually go through the action. It looks, from the outside, identical. What the frame that we're putting around it for them is very different, though. Because in the exposure model, it's, well, you won't pull when this anxiety goes down. From our perspective, it's, yeah, you're going to have this anxiety, and look, you still don't have to pull. And so it's subtle, but it's there.
Does it ever kind of go against, because, you know, we're teaching the competing response, you know, push your shoulder down or whatever, but then we're telling them, no, do the opposite of your competing response?
No, not necessarily. Because what we're, you know, what we're talking about in acceptance, getting them to accept, is not that they're pulling. It's to accept the internal experiences that they have. And so, you know, ultimately, the competing response, think of that as really for the automatic pulling. the focused is really, we don't even really care much about the competing response for focus pulling because it's really not getting at the target variables. Shane?
Oh, I just wanted to say something towards the cutting comment from I have some preliminary data on it, and it seems like it's different from trick in that you see trick starting automatic and then moving into more focused over time, where cutters are normally, they're trying to relieve negative emotions first, and then over time it develops this sort of positive feeling where trick people start with that sort of positive reinforcement habitual instead of the emotion regulation aspect. So I don't know, that helps.
We're going to switch gears a little bit, and then we'll take a break in about 10 minutes to talk about tic disorders. So, switching gears, what are tics? Tics are sudden, rapid, recurrent, non-rhythmic, stereotyped motor movements or vocalizations, demonstrated here by Dr. Gilles de la Tourette, a French neurologist who studied with Charcot. He was in Charcot's hospital in France in the late 1800s, early 1900s, and there are pictures of Charcot holding court in his medical school. There's Charcot, and there's Freud, and a lot of other famous neurologists from France at the time. There was another one there too by the name of Sigmund Freud, who was studying with Tourette at the same time in Charcot's lab. The way he got his fame, Tourette did, working in Charcot's lab, was it worked like any other kind of medical school model lab. Charcot was famous, world famous, and all the strange cases from around the world where local clinicians couldn't treat it, the ones that they thought were the most bizarre cases, they would send to Charcot, much like they do now for medical centers, and they say, we don't know what to do with this. We've tried what we can. We don't know what this is. And so Charcot would collect these cases from all over the world. He got cases from Russia, from Canada, from South America, and they were all sort of describing this kind of uncontrollable movement, and shouting out words and stuff like that. And he collected a lot of these cases, and as any good medical director does, takes them and says, you do the work, Tourette, because I think there's something here. They sent me all this stuff, you do the work, and I write something about these cases. They all seem like there's something there. So in the late 1800s, he wrote this paper about the malady of tics, this illness of tics that he talked about. And he described these people with uncontrollable movements, uncontrollable vocalizations, seemed to be related to a lot of comorbidity. He didn't quite use that word, but ADHD, obsessive behavior. He reported a lot of this stuff early on. He then died very soon after, insane in a psychiatric hospital from syphilis complications. So he had late stage like neurosyphilis, and he died. So he didn't really get to see any fame from his disorder. Charcot, in his honor, called it Tourette syndrome, which is where it got its name. He didn't call it that. And then Sigmund Freud kind of picked it up and ran with it because it really was kind of interesting from his theoretical perspective. People shouting out these sometimes sexually charged obscenities is a perfect example of one's ego strength being very weak in this boiling cauldron of id just popping out occasionally. So he really took advantage of this and had some interesting psychoanalytic interpretations of the disorder. It became, Tourette actually thought of this as a very biological condition. Freud thought of it as a very psychiatric, psychological condition, so to speak. And that conceptualization held for a long time. Tourette's is a psychological disorder, which is why it's in the DSM, actually. I mean, it's kind of an artifact from early conceptualization. That conceptualization of Tourette's as a psychiatric illness that should be treated with psychoanalysis held until about the 1960s, when it was discovered that antipsychotic medications could effectively treat Tourette's. And then the pendulum swung dramatically back the other way and became very much conceptualized as a biological condition. Over the last few years, it's really started to swing back where we realize it's sort of a biopsychological condition, biopsychiatric condition. Tourette's isn't the only tic disorder. Tourette's is just one of them, and Tourette's involves motor and vocal tics, at least 2 motor and a vocal tic that have been present for more than a year. There are other conditions, though, transient tic disorder and chronic tic disorder. Transient tic disorder is basically Tourette's syndrome happening for more than 4 weeks but less than a year. Chronic motor or vocal tic disorder is basically motor or vocal tics, but not both, that have been present for at least a year. The distinction between these is meaningless, frankly. You can have, for example, 15 motor tics and 22 vocal tics that have been present for 364 days, and you have transient tic disorder. Tomorrow you'll have Tourette's syndrome. I mean, that's how kind of ridiculous some of these distinctions are. But they
Is
they
that
still hold.
arbitrary?
Yeah, it really is. Diagnostically in the DSM, it is really that arbitrary. Now, practically, do people do that? No. If you have that many motor tics and vocal tics, even if you've only had them for 8 months, somebody would give you a Tourette's diagnosis. But by the book, that's how arbitrary they are. When you look at, does it matter in terms of comorbidities? Not really. There's no difference. Tics usually start between the ages of 5 and 6, 4 to 6, somewhere there. Usually starts with facial tics, tics of the eyes. Or eye blinking is the most common. Progresses head down. So almost everybody with Tourette's has facial tics of some sort or some tics of the head. Only 60% have tics below the waist somewhere as the disorder progresses. The disorder waxing and waning, a lot of changing of symptoms. New symptoms come, old symptoms go. They get more severe, they get less severe. Tics might go away for a couple months only to come roaring back later. There's a lot of fluctuation in this. Vocal tics, or the sound tics that people make, come later. Usually start a couple years after the motor tics do. The motor tics are movements, vocal tics are sounds. The topography changes, so the tics themselves change. Tics start between the ages of, like I said, 4 and 6. They get worse between the ages of 9 and 12, roughly. 9 to 12, 10 to 14, somewhere in there. That adolescent period is really where the tics peak. From there, about a third get better, their tics go away. Another third, their tics stay the same, maybe get a little less severe. And another third, their tics will stay the same and get worse. So you get that kind of thing. Now, the tics themselves, I don't think I have the slide for this, it must have gotten cut out. But the tics themselves, when we talk about motor tics and vocal tics, they're really, the motor tics are movements, the vocal tics are sounds, but they can also be classified as simple or complex. Simple tics are tics that involve a single muscle group. So like this, that would be a single, like this muscle group's involved. Or an eye blink, or a mouth stretch, or something like that. There's a very discrete muscle group that's involved. It's a very rapid, quick behavior. Simple vocal tics are rapid, quick sounds that people make. Sniffing, throat clearing, barking, that kind of thing. Rapid, quick sounds. Usually, when people first start getting diagnosed with Tourette's, their eye blinking starts first, so the parents take them to the eye doctor. Something must be wrong with his eyes, he's blinking a lot, but yet nothing's wrong. Maybe a year later, 6 months later, there's this cough that just won't go away. Maybe it's a cold, so they wait. 6 months later, it's just not going away yet. So they bring them to the doctor. Doctor says, maybe it's allergies. So they go get the allergy testing if there are no allergies. And then it's only by default that they see that this might actually be a different thing. It might be Tourette's. That's a pretty common way of doing it. There are also a set of symptoms called complex tics. There can be complex motor tics and there can be complex vocal tics. Complex motor tics are tics that are either a specific sequence of simple tics that always follows the same pattern. So for example, this is a simple motor tic, nose twitching. That's a simple motor tic, mouth stretching. This is a simple motor tic, neck twisting. But if you do them all at the same pattern, like that over and over again, that would be a complex tic. All right? So it can be that. Complex tics can also be behaviors that you here would probably see as OCD, but they're not your normal OCD behaviors. They're the kind of things that are, where's that obsession? I can't quite find it. Those kinds of things, not just right OCD is what you'll sometimes call it. And what we would see is something like this. Like if you see somebody come in like this and you'd think that's OCD for sure. I would look at that from my Tourette's lens and say, maybe, but maybe not. That might be a complex tic. You might have complex tics that look something like this. Complex tic. I've seen the butt kicking tic more than I can imagine. Kids who walk along and kick their own butt. I can't do it, I'm too old. You get those kinds of things that happen over and over again. Thank you. So you get those kinds of movements that look intentional. It looks like the person's trying to do it, but it's a complex tic. Okay. Now the question is usually, well, how do you tell the difference between a complex tic and OCD? Behaviorally, it really doesn't matter because essentially you're going to do functionally the same thing. But it might matter pharmacologically. What I look for when I'm trying to tell the difference between a complex tic and OCD is a couple of things. First of all, what are their other symptoms looking like? If the only thing that's making you think they have OCD is that they're doing this, then it's probably not OCD. It's probably a complex tic if they have a history of tics. If they have a whole bunch of other OCD kinds of behaviors and they don't have any history of tics, this is not Tourette's. All right, that's OCD. That's the easy distinction. The question is, what do you do when you really have OCD, like other stuff of OCD, and you really have tics? What you have to think about then is what goes on right before they do this. Okay. What phenomenologically is happening. If they're experiencing physiological arousal, if they're getting anxious, sweaty, physiological signs of anxiety, breathing more, heart rate increases, then that behavior is probably associated with OCD. It's probably more of an OCD symptom. If they have specific thoughts in their heads or images in their heads that is popping up, something negative, something bad, something very specific that they can tell you about what's going to happen if they don't do this, then that's clearly more of an OCD thing. If it's more of a vague, I don't know, I don't feel comfortable, something in there that doesn't feel good, I don't know. This vague sensory discomfort, that's probably more of a Tourette thing. Now you always have the kids that truly are, like right down the middle, not just right. They can't really, nothing bad's gonna happen, but they just don't feel right. What is that? I don't know. You call it OCD, we call it Tourette's, we can treat it the same, we'll all be fine, okay? But there is that kind of distinction right down the middle. Go one more slide. Prevalence of tics. Oh, chronic vocal tics, I forgot to mention that. Chronic vocal tics are words or phrases people say. They're usually actual things you can understand. The most common one, or not the most common, but the most popular one is the swearing, saying the obscene words. That's a symptom called coprolalia. It's actually a very rare symptom. It happens in maybe 10% of Tourette's cases. I've seen very few kids who actually do that. And it's not like you think it is. Sometimes kids with tics will say they have that just to get away with it. Because you can get away with a lot if you tell them it's a tic. But if you hear a kid like, "Hey, fuck you, George!" and they say, "Oh, that was a tic." Sorry. Probably not. I like doing Tourette's talks because I can say "fuck" up here. Nobody knows if I'm ticking or if I'm just a psychopath. So when you get that, when you hear people with Tourette's say full-blown words in sort of a contextually appropriate way, it's probably not a tic. Because a complex, like a coprolalic tic like that, wouldn't sound like that. It would sound more like, even if it came out as a full word, it would sound like, fuck you, that kind of thing. It would be forced, it would be pressured out. More often than not, they know it's coming and they don't even do that. It sounds more like, and they're trying to mask it as it's coming out. They don't want to do this. So there's a difference there. And the last, before we talk about this slide, I want to talk about one more thing and then we'll take a break before we even go to this slide. There's a really key piece of this that's important to understand in Tourette's, and that's that almost all kids with Tourette's, if you know how to ask it, and literally almost every adult, can tell you that right before they do the tic, they feel an urge to do it. This is a premonitory urge. We call this a premonitory urge. A premonitory urge is an unpleasant sensation that either happens in the area of the body where the tic occurs, like a very focal area, or a more generalized feeling of discomfort throughout the body. Okay. If you really want to know what a premonitory urge feels like, I'm going to ask you to do this exercise with me. I want you to open your eyes really wide, like stretch them, but don't blink. Stretch them as much as you can. Don't blink until I tell you to. All right, so go ahead. Stretch them. Don't just stretch them like wide. And notice what you're feeling around your eyes. Okay, go ahead and blink. Okay, what word would you use to describe that feeling? Like write one down. Write a word down in front of you that you would use to describe that feeling. Okay, what'd you write?
Uncomfortable.
Uncomfortable. Anything else?
Awful.
Awful. Pressure. Itchy. Hurt. Tension. Irritating. How many of you wrote something like pleasant? Okay. Delicious. Nobody. It's a bad feeling. What happened right after you blinked? Relief. How many of you blinked a little harder or more frequently than you normally would have right afterwards? Okay. That's what a person with Tourette's is feeling constantly. It's like being bombarded with that feeling throughout the day, of some version of that feeling, throughout the day, either in the area where their muscle is, or generally throughout the body, and when they tick, that feeling goes away. It starts to get up a little bit, they tick, and that feeling gets relieved. Brief relief, but then it keeps coming back. It's like this sensory bombardment. And so, if you think about it behaviorally, there's constantly a reward for ticking. Constant. It's every time they feel bad, this unpleasant feeling, they do this behavior, and it gets reinforced. It gets stronger over and over and over and over again. So why don't we take about till 11, and we can come back and finish.
Guys, again, there's soda and water in the refrigerator. There's orange juice, coffee over there. There's some snacks. Please help yourself.
I got 2 for I figured 60 you're probably more than
Okay, why don't we go ahead and get started again? What's that? I know. That's okay. People actually pay attention here. Everybody's got, well, it used to be newspapers, now it's been dry clothes.
Oh yeah, sorry. I had this nursing student
Nice.
every and she was
Okay, why don't we go ahead and we'll start talking about a little bit more of the background of Tourette's, and we'll talk about the model, the treatment, and outcome data. Tourette's happens, chronic tics are more common than Tourette's, but Tourette's happens in roughly most of the current prevalence data coming out of Scandinavia, which is probably the best prevalence data because of the way they track their population in healthcare. Roughly says about 0.6% of the population has a Tourette's diagnosis. So it's not, that too is not as rare as you might have thought. The DSM puts prevalence rates at about 0.04 to 0.05%, making it an extraordinarily rare condition like an orphan disease. That's way underestimating. The prevalence studies that were done at that time were not very good. There weren't many of them. Much bigger and better ones have been done since then, and it really sets the prevalence at about 0.6%. The tics are described as involuntary, but unlike any other movement condition, except maybe restless leg syndrome, you can actually stop movements voluntarily. Like a person with Parkinson's can be tremoring, but they can't look at their hand and say, okay, stop. You know, they can do that, but it won't stop. A person with Tourette's can stop, at least for a short period of time. The tics are associated with psychosocial impairment and distress. However, the comorbidities that go with Tourette's are much more devastating than the tics themselves usually. So There's ADHD is a common comorbidity, OCD is a common comorbidity. Those are the two most common comorbidities, and those two things really need to be treated first before you even deal with the tics in most cases, because these two things have the long-term impact on functioning more so than tics. That's not to say tics don't have an effect long-term, they can have, but if you've got one of these two things, they're more devastating than the tics are. So generally, if you're sequencing out, you're thinking ADHD, OCD, and then tics. How prevalent these other conditions are is really open for debate. If you look historically at some of the evidence, some data say that up to 90% of cases with Tourette's have ADHD. Up to 60% of cases with Tourette's have OCD. I can tell you that clinically, I've never thought that was true. I thought those were always high overestimates. Coming from a Tourette angle, if you come from an OCD angle and you get kids with Tourette's and they all have OCD, and you might think, oh yeah, it's pretty common. The truth is, though, when a study just came out, it was a study of 10,000 people across, I think it was across the UK, and it looked at comorbidity between tics and these other issues. And what they found was much more in line with what I've seen in my clinic, which is the most common comorbidity in Tourette's, in this big study that was done, this 10,000 person, was actually OCD. And it happened in about 30% of the cases of Tourette's. The second most common was ADHD, which was in about 28% of the cases. Now those are way higher than you'd see in the normal population, don't get me wrong. I mean, there's clearly an association there, but it's not the 60 and 90% you'd seen reported. Now where did that early 60 and 90% evidence come from? Well, keep in mind, nobody really cared about Tourette's research-wise until about 20 years ago, if even that. So what you got, the only thing we knew about Tourette's when DSM-4 was published was really what came from these tertiary care clinics. These Tourette specialty clinics, Yale Child Study Center, for example, which is like probably the biggest, or at least was, is pretty much disbanded now for Tourette's work. But they came from places like that. And who do places like that see? It's really right back to the Tourette model. Those places see the sickest of the sick kids. It's the ones that nobody in the community can figure out. So they send them to Yale to get treated. Yale collects all the data on them, files all the information, and then they report comorbidity rates on their population. But their population is probably a lot sicker than the general population, because those are the kids who nothing worked for them. And so what causes things not to work for people? Comorbid OCD, comorbid ADHD. So you see all these prevalence rates of things otherwise that get higher. Do a general population survey, you start to see more truly what comorbidity rates look like. And there's a lot of comorbidity, don't get me wrong, but it's not as bad as we thought it was at one time. Impact of tics. We asked patients what kinds of problems did their tics cause. 62% said their tics caused physical pain or damage. 8% said they've been hospitalized because of their tics or psychological damage caused by the tics. When we asked children, or parents of children, how did this affect you academically? We know that they missed roughly 3 days of school in the last year because of tics. They were late about 2 days a year, and they had to take unscheduled breaks in the school day about 17 times a year on average in this sample. 12% had changed or dropped out of school, gone to online instruction, for example, because of their tics, usually teasing because of the tics. We asked people discrimination. How have you experienced discrimination because of your tics? 73% said they felt like they've been treated differently because of their tics. 13% had been asked to leave someplace because of the tics. 20% had asked to leave school. 20% felt they had been discriminated against or treated rudely by a business because of the tics. 74% felt abnormal or different because of their tics. 62% felt the tics have led to another psychiatric problem. We asked if parents, if they thought their child's tics ever led them or their spouse to develop another emotional disorder or make an existing disorder worse, and about 34% of parents said that was the case. And 39% of parents of children with tics have sought professional help themselves to help deal with their child's tic condition. Let's talk a little bit about what causes Tourette's, because I think this actually maps nicely onto a behavioral model, and you can understand why we would do what we do behaviorally. We know there's a genetic factor in Tourette's. Concordance studies tell us this. Family history studies tell us this. If you have OCD or ADHD, in your family, your likelihood of developing tics is much higher. They travel sort of a similar genetic path in Tourette's. We know that the genetic predisposition leads to problems in particular circuitry in the brain. The circuitry that's gotten the most attention is the CSTC circuits, the corticostriatal-thalamocortical circuits that go from up here in the motor cortex down into the striatum, through the thalamus, and then back up into the cortex where it gets executed as a movement. What we really think happens is this. I'm going to go into a very mild neuroscience lecture, and I don't know anything about neuroscience, so it's going to be about as detailed as I can do. If you can question me on that, I'll just concede any point you make because I won't be able to argue against it. But normal movement looks something like this. Whenever we walk into a setting and we have to move, the motor cortex in our brain lights up, okay, gets excited, and it sends signals down into the basal ganglia. Now the signals that it sends are signals that are associated with parts or bits of movement. One neuron doesn't make you start doing jumping jacks, for example. If you fire one neuron off, you're not going to start doing jumping jacks right away. But it might activate a pattern of neurons that then gets executed as a jumping jack. The neurons in your brain store bits and pieces of movement like this, that kind of stuff, all right? Little flinch of an eye. Whenever we have to do something behaviorally, all of the signals that are associated with movements we could be doing in a given situation get activated. Those signals get activated and go down, the signals go down into an area of the brain called the basal ganglia. And the basal ganglia are actually a group of structures in the brain that are under the cortex. One area of the basal ganglia is called the striatum. Okay, the striatum, its job is to inhibit unconsciously, we're not talking about a conscious thing here, but inhibit unwanted movements. So when you're sitting in a situation like you're in now, there are some things you're doing. You're doing what you're doing right now, but there are lots of other things you could be doing at this point. And all of those signals for things you're both doing and could be doing are coming down into the basal ganglia, the striatum. And the striatum is saying, looking around to its environment, and it's saying, what's appropriate to do right now? What should I be doing right now? And whatever you should be doing right now gets let through. The stuff you shouldn't be doing, the movements that are associated with what you shouldn't be doing, get stopped. They get inhibited at the striatum. Okay? So the striatum's job is like a gatekeeper. Let through the appropriate movements, inhibit the unwanted movements. All right? Now how does the striatum know what to inhibit? How does it know what to let through? Well, there's another part of the basal ganglia whose job it is to react to the environment. And it reacts to the environment in the following way. If a movement comes through and the environment gives some good feedback to the organism, like a reinforcer, something positive that happens, this other part of the basal ganglia sends a signal back to the striatum saying, whatever you just let through there, do that again the next time it shows up. That was a good outcome. Do it again. If something bad happens, it sends a signal back saying, hey, whatever you just did, don't do that again. Stop. All right? And so what happens is, as the signals come through, the basal ganglia of the striatum checks. Was that a good thing or a bad thing? If it's a good thing, let it through again, a little faster. Kind of like think of the fast security line in the airport, just goes through faster and faster. If it was a bad thing, we block it. That's normal movement. All right? In Tourette's, we know that that part of the brain, the striatum, is about 10% smaller from volumetric studies. There's just not as much of it. We know that the neurochemical that's heavy in that area, dopamine, is a little bit more active than it should be. So the inhibition doesn't work as well. In people with Tourette's, the problem is that braking system in the striatum, that gatekeeping function in the striatum, doesn't work so well. So you get these little bits of movement that come down that should be stopped, but aren't because the gates don't work. All right? So what is a tic? It's that little bit of movement that comes out from the motor cortex that should have been suppressed. And most of us it would have been suppressed. But for them, it just happens to slip through. The question is, what happens after it happens? So if a person has this feeling that I've got to move, and that little bit of movement comes through, and then that bad, unpleasant feeling goes away, there's a feedback system. Remember, good outcome goes right back to the striatum saying, hey, let that through again. That was a good thing. There was a payoff for that. And so you start getting these tics that slip out accidentally, but if the conditions are right, become habitual. They become more habitual in nature. All right? So that really seems to be what's happening when we talk about tics. Now, why can people suppress their tics intentionally? Remember I said this striatum thing is all unconscious. Because the brain has another braking system. there's a braking system from the prefrontal cortex down into the basal ganglia. That's sort of your emergency brake, if you will. It's the thing like if you're getting ready to walk out in the street and you're like, oh shit, I almost walked out in the street, you stop yourself, that's your emergency brake. It's this intentional action of trying to suppress something. So what do we know about that? We know that in people with Tourette's, they actually have an intact emergency brake. This pathway from the prefrontal cortex down into the basal ganglia that you can use to intentionally suppress behavior works perfectly well in people with Tourette's. In fact, in children with Tourette's, that pathway is actually bigger, stronger, more active than normal controls. In adults with Tourette's, it's actually smaller and weaker, which probably tells you something. The earlier you get on this and try to practice suppressing those actions, the better off you might be as an adult. So that's really what's happening biologically when we talk about Tourette's. So behaviorally, what are we talking about? Well, the tics come out because of an impairment in the brain. But the question is, how do they stick around and how do they get worse and how do they change? Well, that's where you have to start looking to the environment. Because as soon as that movement slips out, the brain's looking for what's the reaction to the movement? What's the reaction to the tic? How does the environment change when that tic happens? Is something good happening or something bad happening immediately as this behavior is occurring? So we have to look to our external and internal environment to find out what kinds of changes happen in the environment right after the tic occurs. And is it possible then, if these changes are the right way, if they occur in the right way, that these changes in the environment can make the tics worse than they need to be? We know that tics are heavily influenced by the environment. Our job as behavioral psychologists is to really understand how that works. With as much precision as we can, how do changes in the environment, both the external environment, the environment outside our skin, and the internal environment, what we experience inside, how do changes in that environment affect tics in a predictable way? And how do the tics result in changes in the environment that can make the tics more likely to happen habitually? And if we can understand these relationships with a lot of precision, then we can do something about it, because we control this in a lot of ways. We can do something about the environment and maybe bring the symptoms down. So what are these environment-tic relationships that we look for in tics? Well, we look for antecedents and consequences. Antecedents are those things that come before tics that make tics more likely to happen or less likely to happen. And consequences are reactions to tics that make tics more or less likely to happen in the future. What are some examples of antecedents that affect tics? Places or situations. When I talk to parents of children with Tourette's, I can say, how many of you notice that your kids' tics are worse when they're playing sports or better when they're playing sports? And everybody will raise their hand. How about when they're watching TV? How many of you notice that they're better, or much worse when they're watching TV? Raise your hand. How many of you have noticed that your child's tics are worse or better when they're around a particular person? And they raise their hand. Everybody who knows a kid with Tourette's can tell you that different situations, different things that they do, affect the tics in very predictable ways. They just know that. I mean, there are stories of surgeons who go into the surgical room, as soon as the gloves go on, the tics stop. The gloves come off and they're ticking like crazy. But it's just a very much an antecedent control. They walk into a particular setting and the tics just disappear. And then they come back as soon as they leave the setting. There are consequences that can make the tics worse. Consequences include positive reinforcement, so like others' reactions to tics. Imagine the parent who, let's see if I have this example up here on the slide, I can't remember. No, I don't. Imagine a parent who's sitting there like this. They see their child, and their child's sitting next to a wall, and their child starts to go like this. They get a neck jerking tic, and they start banging their head into the wall, and they keep going, it's more and more violent. And the kid's sitting there crying and weeping and sobbing because they're in so much pain. What is the parent's natural reaction in that situation? What should they want to do? Intervene. Put the hand there, rub the neck, tell the child it's going to be okay, I'm going to get you help, I love you, I'm so sorry you're going through this. I mean, if you don't have that reaction, if that's not your gut reaction as a parent, you shouldn't have your kid. You should just give them away. Because you obviously don't care enough about them. Right? I mean, that's natural parenting instinct. Right? And if I'm doing this talk to parents, all of them, if there are 100 parents in the room, they're all going like this because they've all been there. When the tics get really bad, they really heap it on in terms of caring and loving for their child. And as their heads all going like this, I say, now how many of you put that kind of love and attention on your child when they're sitting there quietly playing video games? How many of you, when they're playing you know, whatever, World of War or something like that, you run over to them and give them a hug and tell them you love them, you sit there and stroke their head, and how many of you do that? And all the parents kind of go like this. Because they know they don't do that. You know, I'm a parent, I've got 3 kids, I can tell you that if my kids are sitting there quietly, not fighting, killing each other, I'm just stepping out. Sneaking out of the room quietly. Because I'm not going to interfere with that. I don't want to mess that up. But now when they start banging onto each other and fighting and screaming, then I have to go over and get involved. And the same thing is true there. And so the parents see pretty quickly that, you know, when you get this big bout of tics, that's when a lot of parental attention comes on. There's when a lot of love and affection comes on. When the kid's sitting there not ticking, there's not much of that. So think of what's happening in the brain. A big flurry of movements come out, the brain's looking around, what's happened? Anything change? And all of a sudden there's a lot of great tactile stimulation that happens as soon as those big bout of tics comes on from mom giving hugs and kisses. And that just reinforces it. Just sends that signal back to the striatum saying, hey, let that through again the next time it's around. Okay? And so it makes it stronger and stronger and stronger. There are other kinds of reactions too. Imagine the child who has no friends and starts using some obscene word, tic-like, in class, and the teacher gets all flustered. All the kids in class are like, hey, that was pretty cool. Do that again. You know, it makes it a little bit stronger. And the kid doesn't want to do it, doesn't like doing it, gets in trouble for it, but that reward there was immediate. It can make it worse. There's also negative reinforcement, escape from situations from tics. Imagine this kind of situation. The child is sitting there and they are asked to read. They're in 3rd grade. Billy, stand up and read for us. It's your turn to take the book and read the paragraph. Billy has a vocal tic, doesn't read very well, kind of socially phobic. But he stands up because his teacher tells him to, and he goes like this. The bass. Who's uncomfortable in that situation? Billy's uncomfortable. Kids are uncomfortable. The teacher feels horrible because she's embarrassing this kid like this. So what does she do? Billy, put your book down. Why don't you go on out to the nurse's office, and when your tics calm down, you can come back in and join us, all right? She's doing that with the best intentions, all right? Protecting the other kid's right to learn, you know, making Billy not feel embarrassed. But what went wrong there? Okay? It wasn't that she should have kept Billy up in front, but what did Billy learn in that situation? When you're stressed, when you've got a demand on you, all you have to do is tick and it goes away. Put the book down, you don't have to read, no expectations, just go. Because of what? Because of the tics. So those kinds of things can happen. And if you want to see a kid who turns into a complete disaster as an adult, you'll see a family who does that a lot, who lets the tics be an excuse and a reason out of everything. It'll be a nightmare of a situation when they're an adult because they have no sense of responsibility at that point. So negative reinforcement, that escape from unpleasant experiences, can also be true. There's another big negative reinforcement that we talked about. That's a really important one, and that's this one, where you get the premonitory urge that shows up, that unpleasant sensory experience. It leads to the tic. The tic then provides relief. The urge is taken away, that unpleasant experience is taken away, just like it went away when you blinked. What that does is set up really a reinforcement contingency that's awfully tough to go after. It's what we in behavior analysis we call a fixed ratio 1 schedule, which basically means every time you do the behavior, it's met with an immediate reward every single time. That's a very dense schedule to go against. It's hard to get rid of that kind of schedule of reinforcement. But it's there. It's immediate and it's there. Now people might sit there and say, well, why would they keep ticking when all this bad stuff happens? You know, the easy explanation is, oh, it's just the brain. Well, it's true, it is just the brain, but it's also the fact that every time they tick, as soon as that tick gets out, that bad feeling goes away. There's a reinforcer there every single time. And yeah, there are bad things that happen with tics when you tick, like you get teased and stuff, but that stuff comes way after the relief, if it comes at all. I mean, there's a good chance you might tick 1,000 times a day and only get teased for twice, 2 of them. But you get reward every single time. You know? So you see the balance, it gets a little bit tougher. So if that's the situation, if that's the kind of the behavioral model that we're working under, how do we treat this? Well, we have to kind of think of the following principles. The person's internal and external environment, both what's inside their skin and outside their skin, can affect the Tourette symptoms. The effects of these factors are unique to the individual. So how it affects one person won't necessarily affect another person in the same way, so you have to be sort of idiographic, individualized when you treat this. And if we're going to do a useful treatment, we've got to deal with both the external factors and the internal factors. All right. Behavioral treatment in general is not curative. It's a management strategy. That's how we think of it. It's an effective management strategy. You haven't fixed the underlying volumetric problem, dopaminergic problem in the brain. It's still there. What we're teaching them is how to effectively manage it. That's not to say brain doesn't change, because we think there are parts of the brain that are changing as a result of this, but probably not the core deficits that have led to the tics in the first place. How do we deal with the external environment? We use this process called function-based intervention, functional-based assessment. What we do is we try to identify in an individualized way the factors that are associated with the tics getting worse in a particular child. So we'll interview the parent and the child. We'll say, I want you to tell me when your child's tics are worse during the day. Not when they happen, but when they're worse. I'm assuming they're happening all day, but give me periods of time, settings, where the tics are happening more frequently or more intensely than usual. And I ask them in a systematic way to go through those situations, and we talk about them. So I'm doing this interview with the mom, and she says, well, the worst time of day is really when he comes home from school, right after school. I say, okay, tell me about that. And she says, well, he comes home from school and he's stressed out and he's anxious. He always goes down to the den when he gets home, and that's where his sister's watching television. And he starts ticking really loudly. You know, he's been stressed at school all day and he ticks a lot. This makes his sister mad because she can't hear the TV anymore, and then she starts teasing Billy and yelling at him, and they start getting into fights, and she can be pretty mean to him. And so before long, he's down there crying, and they're shouting, and he's sobbing because he feels so bad that he can't stop this, and his sister's just laughing at him and so on. And so I have to come down, and I get so mad at her because she's teasing her brother. I send her to her room, and then I look at this poor kid. I mean, he's only 8, and he's struggling with this. He's getting teased. It's probably my fault because my dad had Tourette's, so I probably gave it to him, and on and on and on and on. And so I just sit with him, I give him a hug, and I tell him it's going to be all right, and I calm him down. And then I got to go up and make dinner, so I let him sit and watch TV for a while he calms himself down. Happens 4 or 5 days a week. All right, so if I'm listening to this, what I'm doing in my mind is thinking, what are the antecedents, what are the triggers, and what are the consequences, or what is changing right after he does these tics that could be reinforcing the tics? Well, what are a couple antecedents? There are a lot. One is that Billy's tics get worse when he's anxious. So when he feels stressed, his tics flare up. That could be something. Billy ticks a lot in the den. He goes down into the den and starts ticking. I might ask the mom, what if Billy goes outside and plays after school? Does he tick as much? Mom says, no, he doesn't really. It's just, what if he helps you in the kitchen as you're cooking dinner? No, when he's helping me, he doesn't tick as much. But when he goes down to the den, it's quiet and it's dark, and he just ticks a lot more. Okay, so that den might be an antecedent, going into that situation. Consequences, what's changing? His teasing sister is sent to her room. Now, I don't know about your kids, but my kids, watching one of their siblings get into trouble is like the best show on TV. Doesn't get any better than that. Well, that's not true. The only thing better than that is that they had a hand in getting their sibling in trouble. I mean, if that happened, then it's gold. And so that's a potential reinforcer. Billy gets mom's love and attention in a dose and a concentration that she doesn't normally give it to him when he's just sitting there quietly, and he gets to watch whatever he wants to watch. He gets the TV to himself. So all those changes are happening. Now, is Billy aware of this? Is he a psychopath who's controlling his environment through his tics? No. But could this happen? Sure, it could be reinforcing the things. And so we've identified those situations. What we do then is come up with very simple strategies the family can follow to try to reduce the effect of those environmental factors on the tics. If we think anxiety is making his tics worse, we teach him very targeted relaxation strategies to use in anxiety-provoking situations, going into them, for example. So, hey, you know what? You're at home after school, you tend to be generally anxious. Why don't we take 20 minutes and practice our relaxation exercises right after school? Okay? Then we can watch TV. Something like that. In the den after school, we might say, no more going to the den right after school. You need 30 minutes of playtime outside before you come in the house. Just the way we're going to restructure your day. Instead of having the teasing sister sent to the room, we might say, why don't we bring the sister into therapy with us? So she can learn about what her brother's actually going through. Maybe she'll help, or at least not hurt anymore. Instead of mom comforting Billy, we might teach mom to not react to the tics, but to talk to him about the tics at a tick-neutral time when he's not ticking very much. instead of getting the TV to himself, we might have her turn the TV off or limit the amount of TV time and have him do, you know, homework exercises from therapy in that time. Now what about that? That's how we deal mostly with the external factors. But what about the internal factors? How about this issue? This fixed ratio 1, reduce the urge kind of reinforcer that's always there. How do we deal with that? That's a tough one, actually. What we have to do is to teach the person to notice when they're about to tick, teach them to notice the urge, and give them something that will physically prevent the tick from happening. When it prevents the tick from happening, what we have to then hope is that this premonitory urge will go away. It will fade away on its own. Habituation. The question is, if you ask a person with Tourette's, does that happen? They say, oh, that's never going to happen. This urge won't go away. But they never wait long enough to find out. Might wait 20 seconds at most, maybe 2 minutes. Sometimes it takes a while, though. For me, personally, this has become more obvious as to how important this factor is. We had a patient a few years ago who had a really violent neck-jerking tick, just gruesome neck-jerking tick. Boom, like this, and cracked C4 and C5 back here, had 2 spinal fusions to try to hold things together, lost feeling in the hands. It had really had a pretty profound impact on the patient. And it was actually, the patient was considering deep brain stimulation and had tics for years and years and years. And come to our clinic, and it was, I put it, basically we were the last chance before he started to do deep brain stimulation. He had just come across our website. He drove for a couple hours to get here. And he came in and he started talking. Actually, it was one of my students who was seeing the patient. You remember Mike Walther? Yeah, he, if anybody remembers Mike Walther, I think he spent some time out here. He saw this. In fact, I don't know, Rachel, did you see this case? You might have seen this case on team.
Maybe.
Yeah, you might have. It was one of Mike's first patients, if not his very first patient. And I didn't do a good job of pre-screening this guy, so he just showed up. And I was behind the mirror watching, and Mike was treating this guy, and he was interviewing him, and this guy was talking about how he'd lost feeling in his arms, and his physician had told him at some point he'll become paraplegic or quadriplegic because he'll sever his spinal cord at some point with one of the bones, you know, going through. This was a really violent tick. I mimicked it once, and I felt like I cussed myself and had neck sprain. I'm never going to do it again. But so Mike was sitting with this guy and asked him, how often does this tick happen? And he had other ticks too, but this was his big one. And the guy said, 80 times a day, violent. And you know, as the guy keeps going about how much devastation this has caused him, Mike's turning more and more pale. It's not looking very good. So I kind of got up and ran around and started talking to this guy. Because this was a serious case. I mean, we had never had one that was really sort of life-threatening, you know, that way. So I was talking to him, and I said, you know, I just want you to know what we're going to do. And I said, this neck jerking, we're not going to do it this week. I just want to tell you what the concept of this is, and I want you to think about this for a week and tell me if you want to do it next week. Come back if you want to do it. We're going to teach you to notice this urge. I bet you have an urge somewhere in your neck right before you do this. He goes, yeah, it's like an electric shock. It goes right up the back of my neck. And I said, we're going to teach you to notice that urge, and then we're going to give you something to do that will prevent that tick from happening, and we're going to ask you to do that something until the urge goes away. You know, he looked at me and he goes, that urge goes away? I said, well, yeah, for most people it does. You have to wait a while sometimes. Sometimes you might wait a couple hours the first time. But usually, the more you do it, the easier it gets, you know, so to speak. The more you do it, the quicker the urge goes away. The more you can practice at it. It just does, you know, pretty soon it'll just be like the urge shows up and then fades away. He said, really? That happens? I said, yeah. I said, have you ever tried it before? He goes, I've held it for a minute or two and then it gets really horrible, so I let it go. I said, well, you know, there you go. Maybe you didn't give it enough time. And so I said, don't do anything this week. We'll come back next week. So he leaves. I told him to think about it. He calls. He said, I want to come back. So he came back the next week, and Mike is meeting with him again, and I'm behind the mirror. And Mike starts talking with him, and he goes, how'd the week go? The patient said, it went great. Mike said, oh, you know, how many times did you have the tick? And he goes, about 5 times. And the guy said, Mike said, 5 times a day? That's wonderful, because you were at 80 times a day last week. He goes, no, I didn't say 5 times a day, I said 5 times. And the 5 times it happened looked like this. So I thought, ran around. Find out what's going on. And I said, what? We didn't do anything. We didn't treat you. What happened? And he goes, well, no, you talked about that urge going away. And I was curious because I just wondered. This guy was actually very well educated, doctoral level education. He said, I just decided to try to experiment with it. So as soon as I left her office, I felt the urge to go up, that went up the back of my neck, and I said, I'm not ticking this time. I held my neck tight, and I wasn't gonna let the tick out. And I drove back home, took about an hour to get home, hour and a half, whatever, and the urge was just going up and down. I felt it all the time, and I got home, and I started talking to my wife. I told her what happened in session. I still noticed it. It was right there. I went out in the garden and started gardening, and it was there. And then before long, I realized that it wasn't there anymore. It took about 2 hours. He said, as soon as I realized it wasn't there, it came right back. And I did it again. I'm just not going to let it go. Tightened my neck up and waited. It took about an hour and a half. Then it happened again, and again. And every time it just got a little easier. And by the end of the week, it was like I would notice it was there. I'd tighten my neck up, wait for about 10 seconds, and it would pass. I don't feel like I have to do it anymore. Every once in a while, I'm not paying enough attention. It just kind of slips out like that, but that's it. And that was, I don't know, 5, 6 years ago, maybe. And we still, up until about 2 years ago, we contacted this guy. He was still about the same. He was ticking about 5 times a day. They were mild like this. He'd gotten feeling back in his hands, no further damage. And we didn't have to do anything. What we taught him was the principle, the concept, and I think that's really important in getting that habituation piece down. How do we do that therapeutically? We use a treatment called habit reversal. Habit reversal is a multi-component treatment. It's an old treatment. It's been about 40 years since it's been created. It was invented by Nathan Azrin and Greg Nunn. How many of you have heard of Azrin? A couple of you, CBT crowd. You may not have heard of Azrin, but I bet you've heard of some treatments that he's been involved in creating. How many of you heard of timeout? Token economy? Sticker charts, that kind of stuff. Heavily created by Azrin in large part, not entirely, but in large part. Habit reversal is just one of many treatments he developed. He was actually one of B.F. Skinner's students, and he did a lot of early work in punishment. So everything we know about like aversive shock and all that kind of stuff was actually Azrin, and then he had a change of heart and went more clinical in his career. But he created this treatment that involved 3 primary components: awareness training, competing response training, and social support. In habit reversal, we treat 1 tick at a time. We order the ticks from the most distressing tick that they have currently to the least distressing tick. And generally, once a week, we treat 1 new tick at a time. So we treat head jerking the first week, second week we might go to the vocal tick, third week we might go to, and so on and so forth. Every time we treat a new tick, we use these same 3 procedures. The first procedure is awareness training. In awareness training, the purpose of it is to help the client discriminate episodes of the behavior. So help them notice every time the tick is happening or about to happen in real time. Some people get worried that, oh, you can't make people more aware of their ticks, it'll make them tick more. Not true. There's no evidence for that. Talking about ticks can make them tick a little bit more frequently in the short term, but it's not a permanent thing. Enhancing awareness of ticks does not make it worse. There are 3 techniques that we use to help clients become more aware of their ticks: response description, response detection, and early warning. In response description, what we do is we help the patient define the tick in great detail. We pay attention when we do response description to the muscular sensations that they experience, to the placement of their body, what their body's doing. We as the therapists have to be very observant and fill in what the patients can't recognize. Okay? We want them to have a description of the premonitory urge and describe any bodily signals that suggest the tick is coming, that it started already. Now, if you want, response description is very easy to do poorly. If you read books on habit reversal or manuals on habit reversal, people screw this up constantly after reading this. And here's where they go wrong. The purpose of response description is not to establish a definition that allows the therapist and the client to communicate. That's not it. Okay? The purpose of response description is to make the patient think of this tick in details that they've never thought about before. That's the purpose. In terms of physical details of the tick, getting them to think about it that way. Here's what the difference would look like. Now, let's say I've got a head jerking tick. Okay, looks like that. If I think the purpose of response description as a therapist is simply to communicate with the patient, to be able to communicate about this movement with the patient, response description would look like something like this. We're going to start working on your head jerking tick. Why don't we give me a definition of that? Let's be on the same page. What do we mean by that? And the patient says, I go like this. Oh yeah, you jerk your head. Okay, that's good. And they write down jerks head. Okay. Because we know what that means. We can communicate, right? But that's not the purpose of response description. Response description is to get the patient to think about every little bit of that action. So it would look something like this if we were doing real response description. I would say, okay, imagine I can't see. I want you to show me, or to tell me in words that I can't see, tell me in words what that tick looks like. And the patient will usually start, I don't know, I go like this. I go like this. Well, no, I can't see. What does this mean? Well, I jerk my head. Okay, you go forward or backward? Go backward. Okay, so it looks like this. No, it doesn't look like that. I guess I kind of go back and to the right. So you go like this. Well, no, it doesn't look like that either. And so we start fleshing it out. We get more detail. And as I'm a therapist, I'm sitting there thinking about maybe even doing this tick to see what it feels like. What do I do? What's the first part of that tick? Do you feel it coming? Yeah, I do. It kind of feels like this itchy feeling in my face. Okay. What do you do after that? I don't know. I guess I jerk my head back to the right. No. Why don't you look in the mirror and see what you do? Do it really slow. Oh, I scrunch my nose up. Yeah, that's right. You scrunch your nose up. What happens to your eyes when you scrunch your nose? Oh, my eyes go shut and it gets black. That's right. When your eyes go shut and it gets black and you scrunch your nose, what happens to your lips? Oh, my mouth kind of opens up. That's right. And so you work through the whole thing until they get a level of detail they've never, ever thought about before. And at some point, they usually say that, wow, I never realized I did all this stuff during this tick. When you get that kind of reaction, then you know you've done your job. You've slowed it down enough that they're actually thinking about what they're doing. After you get a good response description, then you do response detection. And in response detection, what we're really doing is sitting with the patient and having them practice in real time telling us when they're ticking or about to tick. That's the early warning training, telling us when they're about to tick. So we'll sit with them and we'll say, look, for the next, well, let me back up. Again, if you read just the manual, you'll usually do this part wrong, okay? Because the manual just doesn't capture what we're trying, even though we say it in the manual how to do it right, people usually just get it wrong. A lot of times when people do response detection, they do something like this. They say, okay, well, we have to practice catching your ticks now. So for the next 15 minutes, we're just going to sit here, and every time you tick, raise your finger. And if you catch it, I'll say good job, and if you miss it, I'll remind you to raise your finger. And that's what kind of the book tells you to do. Raise your finger every time you do the tick and prompt and praise the client. Are you ready to do this? And then they sit down and stare at the client for 15 minutes. And then they wonder why the client doesn't tick. That's how a lot of people do habit reversal in this response detection phase. It's not the way to do it, though. What you do in response detection is you give the instructions. For the next 15 or 20 minutes, we're going to be talking. We're going to be hanging out, doing something. Whenever you do the tick, or even feel the urge to do the tick, raise your finger. Just let me know that you caught it. If you catch it, I'll say good job. If you miss it, I'll very subtly remind you to raise your finger. So if I see you tick and not raise your finger, I'll just say, hey, don't forget. Okay. Now, while we're doing that, I'm not just staring at the patient, I'm having a conversation about something that has nothing to do with ticks. I might be playing checkers. I might be going on a walk. I might be, watching TV. I don't care. Just not focusing on ticks. Because I want them to be able to notice their action, notice that tick, notice that urge in the context of their everyday life. If I can do that, then we've been successful. And so we'll sit there. We might be talking about football or something. And the kid's getting really excited, telling them about the last Packer game. He goes like this and does the tick, and I'll stop and say, oh, don't forget you just had a tick. Don't forget to raise your finger. Oh, I did? Yeah. And we keep practicing. And he's talking about, yeah, Aaron Rodgers threw this pass, and it was a great pass. Hey, you just caught one. That's awesome. So we keep working like that over and over again until the kid's catching about 80% of the ticks. And once they've caught that, once they're aware in real time of the ticks, then we move on to the next phase. And again, we're doing this one tick at a time. The next phase is competing response training. And in competing response training, what we're trying to do is give the patient a behavior to do that's physically incompatible with the tick. In other words, when they're doing the tick, they can't, or when they're doing the competing response, they physically can't do the tick, or the tick becomes much more difficult to do. There are 3 techniques in this: choosing a competing response, having the therapist show the patient how to do it, and then having the patient practice. What are the 3 rules when choosing a competing response? We try to teach the patient the rules. These are the 3 rules in selecting a good competing response. First of all, it should be incompatible with the tick. if they're doing the competing response, they either can't tick or the tick becomes much more difficult to do. Second of all, the competing response has to be less noticeable or interfering than the tick. All right, so it can't be more obvious and bring more social attention to you than the tick. So if you get a little arm jerking thing and the person comes up with a competing response, you know, that's a great competing response. You can't really do the arm jerking, but it also looks pretty weird. Right? So that wouldn't be a good one. The third one, the patient can do the competing response for the required duration, which is a minute, or until the urge goes away, whichever takes longer, across multiple situations. This is where people fall down a lot of times when giving competing responses. Two big mistakes. First of all, one tick, one competing response. Don't come up with multiple competing responses from one tick. Just come up with one. Second of all, it should be something that you can do naked, standing in the desert, okay, by yourself. And I mean that seriously. Don't do something that, you know, like sit on your hands, because you're not always going to be able to sit down. You burn your ass if you're on the desert. You know, there won't be a chair there. So you can't do that. Don't, you know, stick your hands in your pockets. Not a good one, because you might be wearing something without pockets. You know, hold this fidget toy or something like that, squeeze it. Not a good one, because you won't always have the fidget toy. And if you choose to use that, then you've got to come up with multiple competing responses depending on the situation you're in. One competing response, one situation, naked in the desert, you should be able to do it. It has to be some action you can do on your own body. All right? And you should be able to hold that position for a minute or until the urge goes away. Lots of different competing responses. You can see on your handout what they are. The two I want to talk about in particular, because they're more difficult and they don't quite fit the rule necessarily, is eye blinking, which is a really hard tick to treat. I hate treating eye blink ticks because the competing response is not very good. The competing response for eye blinking is fixating, or eye rolling or eye darting, is fixating at a point about 3 feet in front of you and doing soft controlled blinking to look something like this. Blink, blink, 2, 3, blink, 2, 3, that kind of thing. So it's like every second and every 1 to 2 seconds you do a soft blink. That doesn't really fit our rule, because you can still blink while you're doing the soft controlled blinking, but we can't come up with any better competing responses for it. You can't really have them shut their eyes tight, because it doesn't work well if you're walking down the stairs or driving. You can't have them open your eyes like that, you know, and prevent, because then you look strange. So we don't do that. The other thing is the vocal tick. How do we do with vocal ticks? All vocal ticks, doesn't matter if it's coprolalia, palalia, echolalia, any vocal tick at all, sniffing, grunting, barking, they all have the same competing response effectively. And it's not relaxation, but it is a breathing. A lot of people think it's just relaxed breathing. It's not relaxed breathing. It's a particular type of breathing that you would use in relaxation training, but the purpose is relaxation. It's diaphragmatic breathing that goes opposite the pattern of breathing that's involved in making the tick. So for example, if you've got a sniffing tick, how is that tick being made? Inhale or exhale? Inhale through the what channel? Nose, okay? So you would never want a competing response that went the same way, through the same channel. You'd never want a competing response that involved. You wouldn't want that. Why? Because as soon as you start going like this, it would start to tick. You'd always want to go opposite the breathing channel, the breathing pattern. So for a sniffing tick, you'd want to go. If you're doing that, you can't do the tick. It's impossible. Okay? And so you always have to think of the breathing pattern that's involved in the tick and then just flip it. All right? Now you're not doing it that obvious. I'm just exaggerating so you could hear what I was doing. You know, otherwise you sound strange. After you choose the competing response, then you actually it's a decision between you and the patient. Then you demonstrate the competing response to the patient, and you tell them that the way to do this is as follows. If you feel the urge to tick, or you even start doing the tick, go right into the competing response for a minute or until the feeling goes away, whichever takes longer. And this is at any time of day, not just during certain times of day, not just during your self-monitoring, but throughout the day. Whenever this tick happens, do this. It's going to feel like you're doing it a ton right at the beginning, but after a few days it'll get much easier and your ticks will drop dramatically at that time.
If after 1 minute they still have the urge to
They keep going. Yeah. Now, the other thing to keep in mind is while they're doing the competing response, they shouldn't just be excluding everything else. We never want a patient to just stop everything they're doing so they can do the competing response. Oh, wait a minute, I was running down the soccer field, just a sec. We don't want that. We want them to always be engaged in life. So when we teach them to practice the competing response in session, that's how we do it. After they've learned when they're supposed to do it, we say, for the next 20 minutes, we're going to sit here. And every time you feel the urge to tick or do the tick, go into your competing response. But while we're doing that and while you're doing your competing response, keep your conversation going with me. You know, keep talking to me, keep listening to me, keep interacting with me. And we're talking about football or baseball or whatever. And as the child starts into it, every time they do their competing response correctly, we as the therapist praise them. If they miss it, if they start doing the tick but not do the competing response, we stop and say, oh, wait a minute, don't forget your exercise. Don't forget to do that. And we encourage them to get into it, and then we resume our conversation about football or baseball or whatever it is we were talking about. Okay. We keep doing that until the patient shows that they can do this well, and we send them out into the world to do it. We also have a component of what we call social support, and this is where we find a patient or a teacher, a parent or a teacher, and we ask them to do two things. We tell the parent, if you see your child doing the tick, but not the competing response, remind them to use their exercises. Okay. Say, don't forget your exercises. What if they don't listen to me? Remind them once. If they heard you, that's enough. Don't badger them, don't cajole them, this is their responsibility. Once. If you also, the other thing we want you to do is if you see the patient, your child, doing the competing response correctly, so you see them sitting in front of the TV and they go, oh! And then they go, praise them. Say, hey, good job. Good job using your exercises. You'll notice what I didn't say there, Mom, is I didn't say good job not ticking. I said good job managing your ticks. I said, good job using your exercises. I didn't say, hey, way to go, you didn't tick. Because they don't control whether they tick. They control whether they use their exercises. So you really need to support them for what they can do, not what they can't. And so we'll make that point to them. Sometimes we'll add in a reinforcement component. When we add in token economy or reinforcement systems, it's never to reduce the ticks. We don't reward them based on how many ticks they've had for the day and trying to get lower numbers. We don't do that at all. We reward them for efforts at trying to manage. So if they use their competing response as they're supposed to, they get rewarded. If they do their functional interventions the way they're supposed to, they get rewarded. Irrelevant, or regardless of how many ticks they have. We also do something called an inconvenience review, where we, every week, we'll go over all the problems ticks cause, and we want to show them that as week by week they get better control over the ticks start to go down, or the inconveniences go down. Every week and every session, we will go over all the ticks again through this tick hierarchy, re-rating all of the ticks, seeing which one is most distressing this week, and then that's the one we start to target. So we go over and over until the ticks are done. Okay. So outcomes, let's switch gears. Talk about data for outcomes. The empirical basis for cognitive behavior therapy in trichotillomania for adults. There have been few randomized controlled trials. The ones that are there do suggest that CBT, broadly defined, CBT almost always involves habit reversal, stimulus control, and then something else. What that something else is kind of depends on the study. But in general, CBT has generally been effective. HRT has been at the core of all of that, so we think habit reversal is probably a really important element in dealing with at least some of trichotillomania. The problem is relapse has been a problem. Relapse in trichotillomania is common. You see quick reductions and then a return of the disorder at follow-up. My friend Marty Franklin, I think you all know Marty, at least many of you do, he conducted the first randomized controlled trial for pediatric trichotillomania. This just came out. I don't remember the journal though. Blanking on it. I should have put it up here. This is his study, Dave Toland's study. They randomized 24 patients, 12 into cognitive behavior therapy and 12 into minimal attention control condition. There was an 8-week treatment phase followed by a follow-up phase. 7 to 17-year-old participants, IQs over 80, not receiving other pharmacotherapy at the same time, and no other conditions that are listed up there.
What's the MAC condition?
Minimal attention control, like a glorified wait list. Average age for this sample, about 13 years. Average age of onset was about 9. mostly adolescents, majority female and Caucasian. Where they pulled from, the scalp was the most common, followed by eyelashes and eyebrows. We gave a couple different measures. One was the NIMH Trichotillomania Severity Scale. And what we found here, and that primary outcome, when you look at week 0 to 8, the behavior therapy condition brought a significant reduction in the NIMH Trichotillomania Scale relative to the minimal attention control condition. And the MAC condition crossed over at that point, so they were just able to follow up the behavior therapy condition. And what you saw was, at 8 weeks and 40 weeks post-treatment, a significant maintenance of the gains for kids with trichotillomania, which is not something we see very often in adults. What this tells us is that these kids, once they got better, they pretty much stayed better. When you look at overall severity, about 60% had excellent response, defined by NIMH Trichotillomania Severity Scale of less than 2. 60% of the sample in the child sample were considered responders versus none of the minimal attention control condition. And when you look at week 8 and week 16, how many were still responders? 60% of the sample was still a responder at 8 weeks, and 60% was still responding at 16 weeks. So what this tells you is that the treatment gains here are very durable. Once people get better, they generally stay better if they're children with trichotillomania getting behavior therapy. We did a study looking at adults with trichotillomania, and we published this study in Behavior Research and Therapy in 2006, and then wrote this manual, wrote our treatment guide up based on this, and now we're doing a large-scale test of it now, which we're almost done. We were trying to get 84 subjects. I think we've got 75 now in our big study, so we'll wrap up sometime this year and start comparing it. What we did is take this treatment, or the current study that we're doing, we compared this treatment to supportive psychotherapy control conditions, psychoeducation and supportive therapy. In this particular study, we had 10 weekly sessions, and it's still done in 10 weekly sessions. Each session is 60 minutes long, and we try to do the following things. We do psychoeducation, we do stimulus control, we do habit reversal, and we do the acceptance and commitment therapy discussions that I talked about before, a particular sequence of exercises. We also have some self-monitoring to track progress. And what we did is compared this to a waitlist control. We had 28 subjects that were randomly assigned to either waitlist or acceptance and commitment therapy habit reversal, which we're now calling acceptance enhanced behavior therapy for trichotillomania. 3 people dropped out during the study, but they were no different than the completers. And of the 25 completers, 12 were in ACT, 13 were in waitlist. The mean age was 35, 90% female, average IQ, 60% were already on some psychotropic medication, and 56% had some other psychiatric condition. Very different sample than the children. Study design looked like this. We had a blinded independent evaluator who assessed the patient before treatment, after treatment, and then at the follow-up, which I think was a 3-month follow-up. At the end of treatment, the people who wanted, in waitlist, who wanted to get ACT habit reversal were able to get that. So in follow-up, they didn't go into follow-up necessarily. Here's what happened on the main outcomes measure, which was the Massachusetts General Hospital hair pulling scale. You see at post-treatment, from here to here, the waitlist group didn't change. The acceptance enhanced behavior therapy condition saw a significant reduction in pulling severity at the end of 10 weeks, right, in 12 weeks actually, 10 sessions. And then you have to look at what happens, because then 2 different stories get told. The people in waitlist who then got acceptance enhanced behavior therapy reduced. The people who had acceptance enhanced therapy when they went to the 3-month follow-up went back up, although this was still lower than baseline. So there was a little bit of a return, but not to the point where they were no different than they were at baseline. They were still improved at 3-month follow-up, just as not as much as they were at post. Right? Yeah.
So why do you think that the waitlist had such a impressive decline when they had a fairly brief treatment?
Oh, it's the same treatment. Same duration.
But it looks even.
What I think it was my therapist got better.
Ah.
He had more practice. He had already treated 12 patients by this point, so now he was at 24. Was Chad. So he got a little history of everything going through here the last 10 years.
With the Chad effect.
Yeah. But I really do believe that that's what happened. It was just he had a more practiced therapist by that point. When you look at other outcomes, you see the same kinds of things. Significant reduction in daily hair pulling counts for when they got treatment, and again, and that actually maintained, interestingly enough. And then the wait list improved, again, once they got treatment. When you look at mechanisms, this was interesting. We had a measure of experiential avoidance called the Acceptance and Action Questionnaire. And what we found was that the amount of reduction you saw in experiential avoidance, so the more experientially accepting you became over the course of treatment, predicted a greater magnitude of change in the Mass General Hair Pulling Scale. So the less experiential avoidant you became, the more improvement you saw, which was a little bit of evidence of mechanism there. We also know that participation, therapist and participant compliance ratings about the participants' work, the more compliant they were with treatment, the better they did. Tick outcomes. Habit reversal is one part of the treatment that we currently do. What we currently do, we're calling comprehensive behavioral intervention for ticks, or CBIT. It involves habit reversal and this function-based assessment piece, a function-based intervention piece, plus a couple other things. But the core of it is habit reversal. Habit reversal, as I said, has been around for a long time. There's almost 40 years of evidence on habit reversal. And it's almost every study that's been done has shown positive results. The only study that's not shown any difference between habit reversal and its comparison treatment was a study done out of the Netherlands a few years ago that compared habit reversal to ERP. And they found that both were equally effective, which is interesting because they're probably sharing the same change mechanism. The only problem with the study is that the ERP sessions were 2 hours in length and the HRT sessions were 1 hour in length, so they actually got double the treatment time, but the authors never actually accounted for that, which is potentially problematic. I don't know really how problematic, but there is a potential confound there. But habit reversal's been around for a long time. The question is, if you've got a treatment that's been around 40 years and it's effective, and in fact, there's more research done on habit reversal than any medical treatment for Tourette's. If you combine the number of subjects that have been studied for habit reversal, it dwarfs, or the medical studies are dwarfed by that sample size. You know, no drug studies are that big on treatment of Tourette's when you look at the Tourette's as the target. The question is, if that's the case, why is it that 40 years after these data sets have started to come out, do neurologists and psychiatrists don't even know about this? Why is it that this is still not the first recommended treatment, or hasn't been, even though it's been around for 30 or 40 years? I'm going to posit a couple things for reasons that this happened, reasons that you have an effective treatment that nobody knows about, that could help a lot of kids that nobody gets. And my reasons are as follows. First, these studies, 40 years of research, have been published in one of three outlets, primarily. They've been published in the Journal of Applied Behavior Analysis, which is the flagship journal of the Association for Behavior Analysis. They've been published in Behavior Therapy, which is the flagship journal of ABCT. And they've been published in Behavior Research and Therapy, which is arguably the best cognitive behavior therapy journal in the world. Okay, those are the three. How many of you are CBT-minded folks?
Everybody that are
Everybody How many of you have read your latest issue of Java cover to cover? How many of you have never heard of Java until today? It's okay, you can raise your hand. How many of you have read your latest issue of Behavior Therapy cover to cover?
Yeah, cover to cover.
How about Brat cover to cover? And you're CBT folks. Imagine the pediatric neurologist or pediatrician who's seeing this kid for the first time. Are they coming out and picking up their latest issue of Brat to see what's new in the world of Tourette's? No, they're probably not even reading their journals, okay, let alone ours. The other problem we have here is that behavior therapists are really awful communicators in general. We generally are bad at this, and we're bad at this for a couple reasons. First of all, we use language that nobody else uses. Okay, we talk about negative reinforcement and extinction and habit reversal and habituation and exposures and response and ritual prevention. Nobody knows what the hell that means, but we keep talking about it. And to make it worse, not only do we use language nobody understands, but then we get all testy when they don't speak it, and we don't speak it correctly. The behavior analysts are really bad at this. You know, if you make the mistake of confusing negative reinforcement and punishment, somebody will jump down your throat in a behavior analysis convention and tear you up. And we're kind of like, any French people here? We're kind of like the French in that way, you know? You can come to our country, but you will speak our language. Even though we know exactly what you're saying, we're going to pretend not to know what you say and make you speak our language. And then when you make a mistake, we're going to yell at you about it.
Or make fun of you.
Or make fun of you. That's how we as behavior therapists have tended to communicate. Third is we also tend to only talk to ourselves. We pat ourselves on the back and remind each other how great we are. And we don't go out in the world and actually tell people who need to hear it. Okay? You know, we don't send a lot of people to pediatrics conferences, for example, you know, about this kind of stuff.
Or neurology.
You know, or neurology. You know, we don't do that. But yet that's where these people are seen. You know, that's where they enter the system. You know, we're kind of out there in the netherworld in terms of behavior therapy. So we've got to get better at PR in terms of this. One of the things we did about 10 years ago, the Tourette Syndrome Association, a patient organization, came to a group of us who were doing work in Tourette's, and they said, we need a non-drug treatment option. We're getting requests from our patients to give a non-drug treatment option. And our response was, it's been there for years. We already have one. And they said, well, it's not being, we've got to do something. There are problems because it's not out there. So we sat down as a group and we said, well, what are the problems? First of all, habit reversal is great, but it probably doesn't go far enough because it doesn't deal with all of these external factors. It doesn't deal with the functional stuff. So we've got to do that. Second of all, we've got to rename this thing because people hate the name habit reversal when you have Tourette's because it demeans the disorder. It sounds like a simple habit. So we got to change it. Third, we've got to do studies that will be unassailable, that cannot be questioned by the medical community because a lot of these other studies were quirky in some ways, not common for the medical communities. The medical community doesn't know what to do with a single subject experimental design. That's kind of out there for them. So we have to do something that will be written and done for the medical community to understand. So what we did is we created two different grant proposals, one to study kids, one to study adults, essentially the same exact study, and same exact treatment manual, just different age groups. And we wrote grants for each of these. The child study got funded on the first round, which is really rare. Got funded on the first round. It was a 4-year study for $3 million. The adult study got funded on the third round for $3 million for 4 years. And both studies were exactly the same. So now we have evidence on how well behavior therapy works from the age of 9 to like 70 across the lifespan. Both studies looked at essentially the same thing. Took the subjects, randomized them to behavior therapy or a psychoeducation and supportive therapy control condition, 8 sessions over 10 weeks. A blinded independent evaluator, somebody who didn't know the treatment condition the person was in, who didn't treat the patient themselves, assessed the person at baseline, midpoint, and endpoint. Those who were responders got once-a-month booster sessions, and then they were reassessed at 3-month follow-up. I see my time, I think, is off here. 3 months and then 6-month follow-up. Those were the treatment components. You can see those on your slide. I'm going to try to move along a little bit. You can see the inclusion-exclusion criteria. When you get right to the outcome measures, we had 3 primary outcome measures. One was the CGI-I, which to me is the most awful measure ever invented because it's so ridiculous, I think, from a psychometric standpoint. Essentially, it's a 1 to 7 scale saying, how much better do you think the patient got? 1, 2, 3, 4, 5, 6, 7. 1 is very much improved, 2 is much improved, 3 is improved, 4 is no change, 5, on and on and on. Sounds to a psychologist who gets psychometrically ingrained that seriously, that's a real outcome measure? But it is, and it's in a lot of drug studies. You know, and it's kind of like the basis for a lot of things. So we used it. In the YGTSS, which is a standardized tic severity score, YGTSS impairment score, which is tic-related impairment, 0 to 50-point scales, those have much more strong psychometric properties. When we look at the sample characteristics, average age of about 12, mostly boys, average IQ. Interestingly, we let kids in on medications for tics. So if they were on stable doses of medications for tics, we let them into the study. And about 40% were already on tic-reducing medication. This actually works against us as a study finding because presumably the medications have helped and brought some of the symptoms down already. It made it a little more difficult for us. Diagnostic status, most with Tourette's, but you see some comorbidity here. OCD at about 20%, ADHD at about 25%, high levels of other anxiety, high levels of GAD, social phobia, and just other conditions, not as much. At the end of 10 weeks of treatment, 53% of the kids who were in the CBIT condition, the Comprehensive Behavioral Intervention for Tics, 53% of those were clinical responders. That means they had gotten clinically meaningful benefit out of this, CGI score of 1 or 2. 19% of the supportive therapy condition had gotten this benefit. This is for the child study. When we look at tick reduction, significant reduction in tick severity for behavior therapy relative to supportive therapy, significant reduction in tick-related impairment for behavior therapy relative to supportive therapy. And when we look at 6-month follow-up, what we found, this is just for the CBIT kids, there weren't enough supportive therapy kids to really do much with, but 86% of the kids who had responded at the end of 10 weeks were still responders at the end of 3 months. 87% of the kids who had responded at the end of 10 weeks were still responders at the end of 6 months. What this tells us is this treatment is effective and it's durable. When you look at tick severity at the 3 and 6 month follow-up for responders, it remains low. It remains low for tick-related impairment as well. We did something else. If you look historically at criticisms of behavior therapy for Tourette's that emerge in neurology and psychiatry, you see a couple things. You see statements like, yeah, you can bring tics down with behavior therapy, but really it costs the patient. They end up developing a lot of other behavior problems. They get more anxious because they're trying to stop their tics. They get more distressed because they're trying to stop their tics. They get more disruptive behavior because they're trying to stop their tics. There are just going to be a lot of other problems that pop up. So we actually assessed this. This is the child behavior checklist. We wanted to find out, in kids who got better from tics, who were effective at suppressing their tics, what happened to their general level of behavior problems? Well, what happened was, in those kids whose tics were successfully reduced with CBIT, 6 months later, all of their behavior problems were lower. Specifically, they showed less anxiety 6 months later. They were less anxious after their tics had been successfully reduced. They were less disruptive. The disruptive behaviors had dropped 6 months later if their tics had been successfully reduced. What about comparing CBIT to medication? Well, we didn't do a direct comparison. You may not let me do anything. But we did compare it to some other studies that had similar trial designs. Our study came out in the Journal of the American Medical Association, the child study came out in JAMA in 2010, and our adult study, which the results were pretty much identical, came out, except a little bit lower response rate, but came out in the Archives of General Psychiatry about 2 months ago. But we had, in comparison, the child study to 2 common atypical antipsychotic medications that are used. You can see the sample sizes for these are about a quarter of what our study was, and these are really considered the gold standard studies for supporting the use of antipsychotic medication, atypical antipsychotic medication in kids with Tourette's. Much smaller sample. You can see reduction from pre to post on the YGTSS. We might be a little bit lower, but we're in the ballpark of what atypical antipsychotics produce. And atypicals are usually the second line of medications that are tried. When you look at overall effect size, our effect size might be a little lower, but it's brought down in large part by the fact that our supportive therapy control condition was more effective than a pill placebo condition.
And also, your kids had medication.
And our kids already had medications which brought down their effects.
Makes it harder.
We actually did something unique for clinical trials and psychosocial treatments, is that we did side effect profiles every week, just like a med trial would do. And we wanted to find out what were the side effects of behavior therapy, just like you do in a med trial. And what we did is, what you do when you look at side effects is you look for comparisons. What happens in one condition versus the other, and you look for statistically significant differences. And what we found is there were none, essentially, maybe one. People who got supportive therapy were more accident prone. Go figure, I don't know. Statistical error, I think. But we looked at a couple things of criticisms people had given for behavior therapy. Do you get more anxious and nervous when you go through behavior therapy for Tourette's? No. Do you get more disruptive? No. Do your tics actually get worse because you're trying to stop them and that makes them explode? No, that doesn't happen. Does habit reversal make you all tired, cognitively fatigued? No. Those were not happening and they weren't reported in this study. So what this really tells us is that you've got an effective, safe treatment for this condition that's durable, and you don't have the adverse events. This is the adult study. I'm going to kind of buzz through that. Essentially, the outcomes were the same, a little bit lower response rate, no side effects, again. So skipping to the end and trying to get you out of here relatively soon. If behavior therapy for tics is so promising, why is it not more widely disseminated? Well, I'm happy to finally report that it's starting to be. In 2011 and 12, there were some big things that happened for habit reversal for CBIT. In 2011, the European guidelines for the treatment of Tourette's were released. And so now CBIT is listed as the first line treatment of choice for people with Tourette syndrome. If it's available and patients are willing to do it, this should be tried before medication is started, is essentially what they're saying. If they want medication, then you would start with guanfacine or clonidine. So that was a big change. The Europeans are eating this stuff up. I've been over to Norway this summer. I'm going back in the winter, and I'm going to Denmark at some point the next year. They're really liking this stuff because these guidelines were helpful. In Canada, in 2012, the Canadian guidelines for the treatment of Tourette's were released, and they basically said the same thing. The treatment of choice for Tourette's should be behavior therapy first, if it's available and the patient wants it. In the US, I brought this up at our Tourette Syndrome Association Medical Advisory Board meeting in April. I said, the Canadians have done it, Europeans have done it. Don't you think maybe it's time for us to write the guidelines for the treatment of Tourette's that puts this kind of where it should be? And I'm the only psychologist on the group. And the neurologist and psychiatrist looked at me as I was saying this. And as soon as I shut up, one of them turned to another and said, so tell me about that DBS protocol that you were doing, the deep brain stimulation protocol. I'm not sure we're going very far here yet, hopefully, but I'm hopeful.
But that's scary.
Yeah, it is. But we have to ask some questions. How do we teach therapists to do this? The Tourette Syndrome Association actually has borrowed an idea from the OCD Foundation, and that they've started a Behavior Therapy Training Institute, Tourette's BTI basically, just like the OCD Foundation does. We have a 2-day training event that we happen to hold about 3 or 4 times a year, and it's exactly the model that the OCF uses. We do 2 days of intensive training and then 3 months of follow-up phone calls, 3 phone calls over the course of a month, and then you get certified. You can put on the list if you are able to do this. So we've done a couple of those. We've trained probably about 80 or 90 people in them so far. I don't know where the next one's going to be. We just had one in San Diego about a week ago, 2 weeks ago. But the next one's either going to be in New Orleans or in Dallas. I'm pushing for New Orleans in February, right around Mardi Gras, but I don't know that it'll go. So there's a dissemination issue. We're trying to overcome that in the TSA. There's a referral problem in that the neurologists and the pediatricians usually get the referrals, but they need to know about this stuff. So we're doing a lot of work on educating the neurologists and pediatricians and psychiatrists about this. There's still some beliefs about the negative effects of behavior therapy. This idea that if you try to stop your tics, it'll just make your tics worse after you stop suppressing them. It's not true. It doesn't happen. There is no rebound effect. There's this other idea that behavior therapy is like a parlor trick for Tourette's. You can stop one tic, but it'll just make other tics pop up. That's not true either. The evidence that's out there just says that there's no data for that. And so we still need a few things in terms of getting it out there. We need maintenance data, like a year out, 2 years out. We need predictors of response to treatment. Who does this work well for? Who does this not work well for? At lunch, I can talk more about this. We've got some preliminary data to say what's true and what's not. And the other thing we've been doing is we've been really starting to look at dissemination. How do we get this out to people? We've developed an abbreviated version for use in neurologists by nurse practitioners, use in neurology offices. So we've got this 6-session, 20 minutes per session kind of protocol that we're calling CBIT-N or CBIT for neurology clinics. That seems to be working fairly well and might be a good first step for treatment. We've also started to do some some telehealth delivered treatment. So another guy who worked here, a guy named Mike Kimley, worked here a few years ago. He and I have been working on some telehealth protocols, and we've got some data to say that when you deliver this remotely via telehealth, you get some good outcomes. We just completed a randomized controlled trial that was published in Behavior Research and Therapy. And what we found was comparing face-to-face versus telehealth delivered CBIT. You see from pre to post treatment equivalent changes in reductions in tic severity from pre to post for both face-to-face and telehealth delivered treatment. Kids actually like telehealth a little bit better, and they look like they respond a little bit better to telehealth. So this is promising. And then I had a student who just got Emily Ricketts, who was out here last year, who is doing a study looking at whether this can be done over Skype. And so she's starting to randomize into her trial right now, comparing waitlist to Skype-delivered treatment. Her preliminary data were pretty impressive, and we have some evidence that says that you can do assessment of tics over Skype fairly accurately. So these data are starting to roll in, and hopefully this will be a model that we can use to try to disseminate this out more widely. So that concludes my talk. It's only 2 minutes late.
I just had a question. It looked like when you're working with kids, that their gains are more stable across times versus adults who tend to have a bit of a rebound. And I wondered, is that due to in adults these either behavioral or neurological issues become more fixed? And then can you start to think about interventions with kids as sort of a form of prevention?
And that's definitely what we're thinking of it. We've actually developed another manual that looks for behavior therapy for really young kids, like kids 4, 5, 6. As soon as they start to exhibit tics, how to deal with those so it doesn't become more ingrained and become more habitual. So yeah, we've definitely started to think about that.
Anything else quickly? All right, thank you very much for coming. I hope you enjoyed the presentation. I expect all of you to be doing this at an expert level by next Tuesday.
Yeah.